हेमंत.
हॅलो.
हॅलो हेमंत.
हाय सर, आवाज येतोय?
हो. हा मग एकदम.
काय म्हणताय, कसे आहात तुम्ही?
ऍब्सोल्युटली फाईन.
व्हेरी गुड. बाकी काय सर्व व्यवस्थित? काम धंदा जरा कमी आहे हल्ली.
काम धंदा कमी झाला ना, परत आता काय करणार.
आता काय आपल्या हातात काय नाही.
नथिंग.
योगेन सर आलेले आहेत, योगेन सर.
हाय अगेन. अरे तू वरती येऊन जाईल. मनीषा, गुड इव्हनिंग.
हॅलो सर. सर तुम्ही हे लावायला सुरुवात करा ना, तुमच्याकडे पाठवलेत.
कुठं आहे?
तुमच्या सेक्रेटरीकडे. हेमंत तुझं पण पाठवलंय.
कोणाकडे?
सेक्रेटरी मुंबई.
आयला ते मुंबई सेक्रेटरी आम्हाला कधी कोणी भेटत नाहीत. ते त्यांच्या विश्वात असतात. ते आम्हाला आमचं त्यांचं काय, ते दुसऱ्या विश्वात आहेत, आम्ही वेगळ्या विश्वात आहेत.
त्यांना एक मेसेज पाठवून द्या, आम्हाला पाठवून द्या आमचं आलेलं.
त्यांचं विश्व वेगळं हो मॅडम. ते लोक 9 ते 3 मध्ये असतात आणि KM मध्ये असतात. आपला काय संबंध नाही तिकडे जायचा वगैरे. पाठवलं तर बरं आहे. मी तर म्हणतो तुम्ही सेक्रेटरीला पाठवण्यापेक्षा ना ते ऍड्रेसवर पाठवलं असतं तर ते लवकर मिळालं असतं.
हा.
कधीच
कारण
मिळालं
सेक्रेटरी
नाही.
वगैरे सर मॅडम काय महिनोन महिने कोण कोणाला भेटत नाही. मुंबई 11 विकराळ शहर आहे. आम्ही आमच्या दुनियेत, ते त्यांच्या दुनियेत.
बरं मी आता काय करते, तुम्हाला तुमचे ऍड्रेसेस वर पाठवते.
बेटर दॅट वे. कारण ना ते ते ऍटलिस्ट आपल्याला पोस्टाने दुसऱ्या दिवशी मिळेल. हे लोक मला 3 वर्षात एकदा पण नाही भेटलेत कोणी.
येस मी पाठवते. साळे सर तुमचं पण तुम्हाला मिळेल की साळे सर पुण्यात नक्की मिळेल.
पाठवायचं लगेच मिळेल मला.
येस येस. मला ऍड्रेस पाठव हेमंत, ऍड्रेस पाठव, मी पाठवते.
मी पाठ
ओके ओके.
आपण लवकर जॉईन झाले ते बरं झालं.
नाही ते बरं झालं, कारण काय ना टेक्निकल एरर्स वगैरे काय असल्या ना तर ते लगेच सॉर्ट आउट करता येतात.
आणि 7ला चालू करूयात ना आपण.
हो, पण आपले स्पीकर्स तर येऊ देत.
मी त्यांना सांगितले लवकर या म्हणून.
योगेन सर आलेले आहेत, म्हणजे ते योगेन सर बरोबर चाबूक लावणार.
नाही नाही, म्हणजे आपल्याला काय करायचंय, साधारण हे दोघं जण 7:30ला जॉईन व्हा सांगितलंय. तर ते दोघं जॉईन झालेत, व्यंकटगिरी सर आणि नवीन मल्होत्रा सर, की आपण आपलं असलेलं डिस्कशन थांबवून वी विल गो फॉर मिसा न्यूज रिलीज आणि देन वी विल कंटिन्यू विथ डिस्कशन. साधारण
चालेल. अभिजित
ती जॉईन झाली आहे, अनुश्री जॉईन झाली आहे, मिनल पण जॉईन झाली आहे.
ते लोक त्यांना त्यांचे टेक्निकल हे करून घ्यायला हरकत नाही, स्लाइड्स आणि हे, किंवा त्यांनी ते केलं असेल अभिजित बरोबर.
नाही नाही, आता करतील ते.
हम्म.
त्यांचं अजून कनेक्टिंग टू ऑडिओ चाललंय. मिनल आणि अनुश्री, गुड इव्हनिंग.
म्यूट आहे मिनल.
गुड इव्हनिंग मनीषा मॅडम. गुड इव्हनिंग ऑल.
हाय अभिजित.
गुड इव्हनिंग. गुड इव्हनिंग.
योगेन सर.
क्या बात है. नाइस टू सी ऑल ऑफ यू. गुड टू सी. मेरे पीछे थाना का वो है, मैं जहाँ निकालता हूँ थाना का.
मैं भी 1 सेकंड हिल गया. आप थाना कहाँ शिफ्ट हो गए?
मनीषा मॅडम तुम्ही म्यूट आहात बहुतेक.
नाही, मनीषा मॅडम बोलत होते आता.
कुठे आहे ते व्हर्च्युअल बॅकग्राऊंड स्टॉप करायचे ना आता. नाही, माझा घरात खाली आलाय, इथे टाकतो मी आता. मला वाटतं
आमदार सर आले.
Hello.
हाय सर.
Hi, how are you?
एवरीवन इज फाइन.
તારા માટે ખાસ વહેલો ઉઠીને બેઠો છું.
Enjoying.
सर इज इन US I think.
નમસ્તે મેડમ.
नमस्ते सर, नमस्ते. तुम्ही एन्जॉय करताय. गुड मॉर्निंग.
ગુડ મોર્નિંગ, ગુડ મોર્નિंग.
अविनाश पण जॉईन झालं.
कामदार सर कुठे बसून ऐकतात तर माहित नाही. कुठे आहात साहेब?
अमेरिका.
शिकागोमध्ये?
નહીં, બોસ્ટનला आहे.
बॉस्टनला आहे. हा, म्हणून ते -5 डिग्रीचे फोटो पाठवतात आजकाल.
आणि म्हणून त्यांचं कॉफी आणि मॉर्निंग ब्रेकफास्ट चाललंय. मिनल आणि अनुश्री तुम्ही लॉग इन झालात का? अनुश्री, मिनल लॉग इन झालात का?
मॅडम दिसत नाही आहेत ते दोघी जण अजून.
आता झाले त्या प्रोजेक्ट. फोन करायला लागतील केळकर मॅडम ना.
माझा बॅच अजून खाली असते.
योगेन कहाँ तक आ गई तैयारी?
बस सर चल रहा है अच्छी तरह से.
हाँ,
गोइंग ऑन नाइसली. शिल्पा मैडम इज देयर इन टच विद डॉक्टर मनीषा.
hotel is booked.
नाही, that part we are in finalizing stage now.
Which hotel?
आता बघतो सर कसा बजेट मध्ये बसायला पाहिजे ना.
आमचे रूम जिथं आहे तिथं आमचे रूम बुक करून ठेव.
हो, ते पुण्यालाच ठेवतो मग.
नो प्रॉब्लेम.
I'll
हयात
shift,
बुक करो का इकडे?
I'll shift the conference to Pune. That will be cheaper for me maybe.
हाँ, हयात बुक करेंगे, नो प्रॉब्लेम.
बघतो. ते चालला आहेत कार्यक्रम सर. येस.
नाहीतर JW.
बघू आता कसं काय बसते. बजेट मध्ये बसायला लागेल ना. एव्हरीबडी इज बजेट हंग्री हो. सब लोग
You are the budget for Maharashtra. What you are talking, man?
क्या बात है.
You are the budget for Maharashtra. Hemant,
सर.
he is the budget for Maharashtra.
अरे सर बरोबर आहे, पण त्यांचं पण म्हणणं बरोबर आहे ना.
ऑल होटल्स आर सो मच आउट ऑफ बिजनेस कि दे आर सब वसूल करने को पड़े हुए अभी एक्चुअली.
एक तो काम बिजनेस नहीं है उन लोग के पास, और स्पॉन्सर अपने लोग बोलेंगे कोविड के में धंधा नहीं है, तो फिर हम लोग कहाँ से आपको पैसा देंगे.
Farmers are not able to share and nor are the hotels willing to come down. Things are not easy.
या दोनों तरफ से तबला है.
Hey, Dr. Hemant, I met one of your person who knows you very well.
Who, sir?
One lady, her husband, काय नाव त्याचं? ते गोरेगावला राहतात. Amit's mother.
Oh, yes, Kolumbekar. Ranjana. Oh, yes. She is my father's student. My father was the principal of Ruparel College, and her husband used to be actually my father's student, same department, organic chemistry. Then he became the professor. Unfortunately, few years ago, he just died pretty young. I mean, 62 or something. After that, she is pretty devastated, but now she's pulling up. Recently underwent TKR in breech candy, and now she is must be with her son in US.
Yeah. In
Yeah.
Chicago, we met her.
Yeah.
So we were just talking about. She came to know that we are anesthesiologists. She started telling me, and I
Yeah.
said, I know all of them very well.
Absolutely, sir.
अनुश्री आणि नीलन, तुम्हाला तुमचे स्लाइड चेक करायचे आहेत का बघा. अनुश्री, प्लीज चेक युअर स्लाइड.
हा मॅम, एकदा शेअर करून बघते की याच्यावर. येस मॅम.
प्लीज. नीलन, यू ऑल्सो.
Yes, madam, I will share. Yes.
मॅम दिसतंय का?
नाही ग, तू शेअर नाही केलंस अजून. यू हॅवंट शेअर द स्क्रीन.
Yes. Menial, we can see your slides.
Now you can make it PowerPoint, full PowerPoint presentation.
येस मॅडम, खालच्या साईडला पॉवरपॉइंट मोड मध्ये टाका. येस येस, परफेक्टली फाईन दिसतंय.
फक्त मिनल
एक दोन स्लाइड पुढे मागं करून बघताय का मॅडम?
ऍडव्हान्स स्लाइड करून बघ बाबा, पुढे पाठी होतंय की नाही.
माझं
हा, होतंय.
येस येस येस.
परफेक्ट.
Yes.
मला हे मॅम कनेक्ट टू म्हणजे साइन इन असं येतंय.
हॅलो.
Nilan, we can see your slide.
Okay, madam. Yeah.
Nilan, तुझं sharing आता हे कर, बंद कर.
Okay, okay.
We can share our screen.
तिकडे जेवून बसू.
माझं शेअर स्क्रीन, शेअर कंटेंट दाबायला लागेल ना.
Share screen खाली.
मॅडम, शेअर स्क्रीन दाबा. शेअर स्क्रीनला क्लिक
हा.
केल्यानंतर तुमचं डेस्कटॉप शेअर करा पूर्ण. दॅट विल बी मच मोर इझियर.
नाही, ऍक्च्युली आयपॅड वरनं करते मी. लॅपटॉप वरनं करू का?
आयपॅड वर इज ऑल्सो फाईन. शेअर कंटेंट करा.
केला की स्क्रीन फोटोज मायक्रोसॉफ्ट शेअर पॉइंट
स्क्रीन करा. स्क्रीन करा. स्क्रीन
केलं. स्क्रीन ब्रॉडकास्ट, एव्हरीथिंग ऑन युअर स्क्रीन विल बी.
येस करा. येस
स्टार्ट ब्रॉडकास्ट.
येस प्लीज. येस
आलंय का काय?
झालंय. आता तुम्हाला प्रेझेंटेशन ओपन करायला लागेल फक्त. युअर स्क्रीन इज विजिबल नाउ.
प्रेझेंटेशन पण मग कुठून करू ओपन?
याला मिनिमाइज करा मॅम. येस.
ओके.
Yes.
आता येतंय का?
हो, दिसतंय. स्क्रीन स्लाइड चेंज करून घ्या फक्त. एकदा बघून घ्या. दिसतायत मॅडम. ऑल वेल.
ओके.
तुम्ही ब्रॉडकास्टिंग बंद करू शकता. वरच्या साईडला रेड कलरच्या याच्यावर टॅप करावा लागेल.
हा.
ओके.
Madam has joined. Dr. Samir has joined. Avinash has joined. Kelkar madam has also joined. Students are there. Should we start?
Actually 4 minutes. 4 minutes still there to 7.
32 people already joined.
Hello.
4 minutes थांबूया.
Hi Avinash.
Hi. I just came from the workshop.
हॅलो, मी होते मनीषा. 2 मिनिटं.
मॅडम आलेले आहेत. केळकर मॅडम, गुड इव्हिनिंग.
गुड इव्हिनिंग.
तुम्ही दिसत नाही खरं आम्हाला अजून. तुम्ही जॉईन झालाय
मी अजून व्हिडिओ ऑन नाही केला. करते 1 मिनिट.
Hello, Sai sir.
गुड इव्हिनिंग.
Good evening.
अंजली मॅडम, गुड इव्हिनिंग. तुम्ही खूप थकलेला दिसता आहात. यू आर लुकिंग व्हेरी.
Good evening. संध्याकाळ झाली की थकले म्हणजे वयामुळे होत असेल तसं.
No, no, no. How can you say like this? Not so. काय
अविनाश
म्हणते ते, काय
धावतोय.
म्हणते?
आय थिंक
नागपूरला
अविनाश धावतोय.
काय म्हणते?
अविनाश धावून राहिलाय.
नाही नाही मॅडम आलोय आता धावून म्हणजे वर्कशॉपला धावलो. एक 3 तासाचं वर्कशॉप होतं आमचं CPR वर. खूप चांगलं झालं. इंट्रोडक्शन CPR, बेसिक, ऍडव्हान्स, नंतर निओनेट, पिडियाट्रिक, इन्फंट, नंतर ओबेज काय प्रेग्नंट पेशंट आणि इन हे कोविड पेशंट.
म्हणजे
तर
पुढच्या
असं
प्रोग्राम साठी काही ठेवलं नाहीये तू.
असं म्हणजे मॅरेथॉन वर्कशॉप झाला मॅडम.
गुड.
व्हेरी गुड.
आणि IMA साताराने ऑर्गनाईज केलेली कॉन्फरन्सची सुरुवात होती आज उद्या आणि परवा 3 दिवस कॉन्फरन्स आहे.
इव्हन डेमॉन्स्ट्रेशन ऑनलाईन डेमॉन्स्ट्रेशन पण ठेवलं होतं
लार्डेल बरोबर. लार्डेलचं QCPR क्लासरूम आहे ना, त्याच्या एक फार नाही वेळ देता आला. 5 मिनिटं आपल्याला देता आलं.
पण छान झालं ते.
हो
प्रोग्राम. मग ते इनॉग्रेशन होतं, त्यानंतर संपूर्ण मी आता आलोय. We can start now, madam. It's 7.
आणि 50 मेंबर्स आहे स्क्रीनवर आता. हो द्या.
ओके. अशोक देशपांडे सर,
सातला अजून 1 मिनिट कमी आहे.
अशोक देशपांडे सरांचा मेसेज आहे that there is some family matter, so he is unable to join. तर मग आपण त्यांना तेच आता वाट बघत होते त्यांची. I could not see him. There is some problem. So Ashok Deshpande sir is not joining, so we can start.
Just wait for 1 minute. I can 6:59. एक 1.5 मिनिट थांबूया.
तर आज बर का रेकॉर्ड रजिस्ट्रेशन झालं, जवळजवळ 1100 रजिस्ट्रेशन झालं. 1100 म्हणजे 1100 रजिस्ट्रेशन. हॅलो हॅलो, माझा आवाज येतोय का?
हो
Continue.
क्लिअर आहे अविनाश.
तर 1140 रजिस्ट्रेशन झाले मॅडम आज.
कुठे?
Very good, excellent.
IMAच्या
हो,
इव्हेंटला.
IMA ला
व्हेरी गुड, व्हेरी गुड.
1140 रजिस्ट्रेशन.
फारच छान.
Excellent. You cannot call it CM, you can call it a college only.
कॉलेज बरोबर MMC पॉइंट्स सर. मेनली इट इज फॉर MMC पॉइंट्स.
Excellent job, very good job.
तर फायदा एकच झाला, म्हणजे वी विल इन प्रॉफिट. IMA विल बी इन प्रॉफिट विदाउट एनी एक्सपेंडिचर ऑन एनिथिंग.
हो ना, फूड वगैरे काहीच एक्सपेंडिचर नाही
ना.
How much you have charged, Avinash, for the registration?
1000 for IMA members, 2000 for non-IMA members.
Very good, excellent.
10 लाख का धंधा हो गया सो. 10-15 लाख का धंधा हो गया ऐसे.
But we people was there at the venue, and we were doing live broadcast.
Fine.
Our lectures were live there.
I think that deserves a big hand.
Yeah, and all the participants were from Satara IMA only. Hardly 1 or 2 are from outside. All 3 days.
The whole district joined.
Yeah, whole district, no, whole Maharashtra.
Very good.
Those who have required points for MNC, they all joined there.
Great. Really great. Great.
We can start actually.
Yeah.
You see 78 members on screen already. Let's start.
77. We can start.
अविनाश सर, चालू करूयात का?
हा, चालू करा मॅडम.
नाही, अविनाश आपले जनेकाचे अविनाश.
Yes, ma'am. Yes. चालू करा. Yes.
Thank you. Yeah, you have to start the recording, please. Yeah.
जस्ट अ मिनिट, मी स्क्रीन शेअर करतोय. दिसतोय माझं स्क्रीन? Okay, over to you, Manisha madam.
Thank you so much. Good evening, everyone. I'm so happy to see so many of the people. Always the participants are 100 on the Zoom platform at exactly 7 o'clock. Only 2 minutes are over after 7. Respected Vice President of ISA National, Dr. Anjali Bhure. Respected Maharashtra State Chapter ISA Office Dignitaries, Dr. Sale Sir, Dr. Anita Mehte, Dr. Avinash Vosle, Dr. Samir Sohni, and Dr. Hemant Shinde. Respected moderators for today's academic interactive session, Dr. Kalpana Kelkar Madam and Dr. Yogen Bhatt Sir, and today's faculty, young and enthusiastic, Dr. Heenan and Dr. Anushli, and all the members of Maharashtra State Chapter ISA, a very good evening to you all. In this fourth series of interactive session that we have arranged, we will be discussing various case scenarios and how I do it, and there will be discussion with moderators for that particular case. We all know that obesity has become a global epidemic, and in India also the morbid obesity is increasing day by day, and if we know the exact prevalence, then almost 5% of Indian population has been affected by morbid obesity. India ranks third in global obesity index, and yes, the obesity patients coming for day-to-day anesthesia cases are also increasing. So here we are today discussing the common problem, that is obese pregnant patient and an obese patient coming for an emergency laparotomy. And we will discuss all the points, how I do it by the dynamic faculties as well as by the experts and the moderators. So let us begin with today's session. I hand over the mic to Dr. Anita for further proceedings.
Thank you, Dr. Manisha Madam. Now I introduce our today's moderator, Dr. Kalpana Kelkar Madam. Akhilesh, please. Akhilesh, can you mute others?
Akhilesh or Abhijit, there is a disturbance in sound. Hello? Akhilesh?
Is my screen visible? Can you see the screen?
Yeah, we can see the screen.
We can see the screen. Please.
I request all other members to mute except Dr. Nehate Madam. Thank you.
So actually, Dr. Kalpana Kelkar Madam, I welcome Dr. Kalpana Kelkar Madam for today's session, and Madam does not actually need any introduction to Maharashtra. Madam is a very senior anesthesiologist, and she has been ex-professor and head of department of anesthesia of BJ Medical College, Pune for many years, and I am fortunate to have worked under Madam for many years. Madam at present is professor and head of department of critical care medicine at DY Patil Pune. She has hundreds of students all over Maharashtra. So a very well-known figure. We are very fortunate to have Dr. Kalpana Kelkar for today's session. Also, Madam is a poetess and has a keen interest in classical music also. A very dynamic personality. I welcome you, Madam. And I request Avinash to introduce Dr. Yogen Bhatt, sir. Avinash?
Avinash?
Avinash sir must be on the mute.
Hello.
Yes.
Thank you, Anita. It's my pleasure to introduce Dr. Yogen Bhatt, sir. Sir has done his MBBS from GMC Mumbai in 1975 and DA in 1978 from GMC Mumbai. He is practicing since last 42 years. He had received National Award of Proficiency in of ISA in 2015, then National Award COLS in 2021. He is president of ISA Borivali City Branch, Department of Anesthesia, Shatabdi and Bhagwati Hospital, Nama Hospital, Vardhan Hospital. Most important, sir, is leader of the 29 anesthesiologist members in his group, and he is doing group practice with them. And now I also declared that sir is organizing chairperson for our next biennial CME at Borivali. Thank you, sir. Over to Anita. Hello.
Hello. Yeah, I request Samir to introduce our today's speaker, Dr. Meenal.
Good evening, everyone. Our first speaker for today's interactive session is Dr. Meenal Harde. She is Associate Professor at PNMC and BYL Nair Hospital in Mumbai. She has 21 presentations in her credit in national and international journals. And she has written 6 chapters in various anesthesia-related books. So she is also winner in the Nagpur State Conference in the teachers category. So I will request Dr. Meenal Harde, madam, to begin her topic presentation. Thank you.
Thank you very much for the kind introduction. I will share my screen. Is it seen?
Yes, Dr. Meenal.
Yes.
Thank you very much, and thank you very much, Team ISA Maharashtra State, and greetings from Mumbai. I will be briefing about the anesthesia challenges in obese parturient. As Madam said, obesity has been declared as a global pandemic, and it is the prevalence is rising more in women than in men. Percentage of morbidly obese women has doubled in the last decade, and hence the number of obese parturients coming for anesthesia are also ever rising. These patients are at increased risk of having perioperative complications, and recent maternal and child health care inquiry, which is published in the BJA, has mentioned obesity as a major risk factor for maternal morbidity and mortality and neonatal morbidity. Also, WHO systematic analysis of closed claim suits has pointed obesity as a major cause of perioperative complications and anesthesia-related maternal mortality. And hence we need to cover this topic in detail with relation to anesthesia management in elective and emergency LSCS. So this patient, 33-year-old primey with precious pregnancy, 124 kg and BMI of 34, known case of gestational diabetes mellitus, pregnancy-induced hypertension and obstructive sleep apnea, came to us for emergency LSCS. On admission, she was diagnosed COVID positive. She was posted for emergency section in view of large baby and fetal distress. On examination, on quick history and examination, she was having short neck with heavy pad of fat around the neck and a mild scoliosis. She was MPC3 with large tongue. Vitals were acceptable with blood pressure of 160/90 on labetalol, and however, oxygen saturation was 90% on room air with air entry decreased in bilateral basis. Basic investigations were available which were acceptable, including coagulation profile and platelets were normal. However, blood sugar was very high. Keeping everything ready for the difficult intubation and confirmed high-risk consent and post-operative ICU care, anti-aspiration prophylaxis was given and patient was induced with combined spinal epidural anesthesia with a low-dose intrathecal bupivacaine followed by graded epidural. Left uterine displacement was maintained with a wedge under the right buttock, and as soon as the patient was made supine, saturation was even falling further in spite of oxygen supplementation, and hence ramp position was given using pillows and towels, and CPAP was attached intraoperatively, which instantly improved the oxygen saturation to 99%. And she had a stormy post-operative course mainly due to the obesity, COVID, and postpartum complications. She required continued CPAP and low molecular weight heparin, had a long recovery, and discharged after 15 days, 20 kgs lighter. So obesity in pregnancy is becoming common, but still the exact definition is not clear. Pre-pregnant BMI more than 30% or more than 20% increase in weight during pregnancy may be defined as obese parturient. Various indices to gauge obesity are ideal body weight, which is height in centimeter minus 100 for males and 105 for females. Body mass or Quetelet index, which is weight upon height square, and lean body mass, which is used for calculating various drug doses. WHO has classified obesity into parameters for mainly health risk stratification, and anything above 30 BMI is associated with moderate to severely increased risk factors. Obesity, pathological changes and the physiological changes of pregnancy have compounded effect on each and every system of the body, which increases the perioperative risk significantly. CVS faces the major brunt with supine hypertension syndrome is exaggerated extremely, and so is the incidence of preeclampsia. In addition, chances of cardiac comorbidities like coronary artery disease, arrhythmias are increased by almost tenfold. Hence, if time permits, in elective cases, detailed cardiovascular evaluation should be done in these patients. These patients have potentially difficult airway, and chances of mask ventilation, difficult intubation is common. And compromised pulmonary functions are also known due to decreased volumes and capacities, small airway closure, airway obstruction, and OSA, which is very common in these patients. And all these things make these patients highly susceptible for early day saturation and perioperative pulmonary complications. There is 4 to 10-fold increased risk of preeclampsia, GDM, and obesity metabolic syndrome and pulmonary embolism, which has been documented as a cause for sudden maternal deaths in obese parturients. Vaughan et al. Has found that 60% of obese parturients had microaspirations, and it is due to increased gastric volume, decreased gastric pH, and delayed gastric emptying time. And these patients are at high risk of Mendelssohn syndrome, and hence the anti-aspiration prophylaxis can be stressed more over here. Pharmacodynamics and pharmacokinetics is altered due to the changes in volume of distribution, lipid solubility. There is higher sensitivity to depressant effects of sedatives. MAC is decreased. As the net effect is unpredictable, use of dosing scalar is recommended, wherein they recommend administration of drugs based on ideal body weight. Most of the drugs, however, only benzodiazepine and neuromuscular can be blockers can be used on ideal body weight. However, rest of the drugs can be used on lean body weight. Neuraxial local anesthetic, already in parturients, the dose is reduced. in obese patients due to the increased scaphoid spread is noted due to excessive adipose tissue in the buttocks causes relative trendline work position of the spine, and as such due to increased abdominal fat and pannus, CSF volume is decreased. However, the various studies have mentioned that the dose need not to be reduced, but watch for higher scaphoid spread and control the level. Obesity in pregnant female causes numerous consequences both in fetus and mother, including increased risk of cesarean section, prolonged surgery, hemorrhage, and even mortality. In fetus, there is increased risk of congenital malformation, stillbirth, perinatal mortality. And the anesthesiologist should be involved in the care of obese parturients as early as possible, right from the antenatal assessment period, which is in the later third trimester, preferably to formulate a plan with a teamwork and plan for labor analgesia and or elective cesarean section, and also make arrangements for optimum post-operative care. Early assessment here is essential for multidisciplinary management of the patient, and whenever the patient is admitted for delivery, again detailed re-evaluation with respect to history, airway, systemic examination, and whether the blood pressure and other parameters are controlled or no, and any particular specific evaluation from cardiology or pulmonologist is needed, whether CPAP needs to be started right from the preoperative period, that needs to be evaluated and started. The aim here is to reduce the perioperative complications and improve the outcome. So preparedness is optimally essential, and we have to ensure ICU or HDU care in the post-operative period, adequate blood sugar, blood pressure monitoring, and optimization, thromboprophylaxis. Either mechanical can be started in the preoperative period and may go to pharmacological in the post-operative. Chest physiotherapist needs to be involved early, and incentive spirometry, deep breathing needs to be started right in the preoperative period. Weight limit of the operating table with side support and table extenders should be checked. Adequate sizes of non-invasive BP cuffs, difficult airway card, different sizes of regional anesthesia kit with extra long needles, and if need arises, readiness for CVC cannulation and arterial cannulation should be confirmed. These patients have compounded risk and limited physiological result, and difficulty arises right from positioning, vascular excess, airway regional, and of course watch for supine hypotension syndrome. Now, elective labor analgesia in these patients is highly recommended and has numerous benefits. Like it can be augmented for instrumental vaginal delivery and cesarean section. So recommended is either lumbar epidural analgesia if you are starting in the early stages, or combined epidural and spinal if in the later stages. For cesarean section, unless contraindicated, the anesthetic technique of choice is central neuraxial anesthesia, and it is highly stressed in the obese parturients. However, irrespective of the technique used, standard care for cesarean section and mainly in obese parturient is highly emphasized, which includes aggressive anti-aspiration prophylaxis. Mainly reducing the pH with sodium citrate is essential as microaspirations is common. Preventing supine hypotension with left uterine displacement, preferably by wedge under the buttock, as stable tilt is difficult in these patients, and patients should be firmly secured to the operating table before tilting, even mild. Pressure area should be adequately padded. Oxygen supplementation is highly ensured, while even transporting the patient, oxygen should be on. Additional experienced help and preparedness for anticipated and unanticipated complications is crucial. Single shot spinal anesthesia is also a widely practiced and a successful technique. It has fast onset, reliable, and dense neural pocket. However, certain concerns we need to keep in mind are technical difficulties and potential for exaggerated spread. Also, the surgery duration usually in these patients is prolonged. And so these things can be kept in mind, and still spinal anesthesia can be planned. The dose, however, need not to be reduced. Control the level by adding the pillow under the thorax, and additives may be added. However, if the opioids are added like fentanyl or any other longer acting, we need to monitor the patient additionally for delayed respiratory depression. Combined spinal epidural is the preferred and recommended technique, and so we use this in our patient. It has a fast onset and immediate onset also, and the sympathetic blockade is limited and controlled due to the graded titrated epidural block. Needle through needle technique is easier to perform in obese parturients. And the time taken for CSE as opposed to spinal is not increased. We can definitely perform CSE even in emergency situations. However, with epidural or CSE, unintentional dural puncture has been reported commonly in obese parturients. And in that case, the plan of action as recommended by multiple meta-analysis and studies is to convert it into continuous spinal anesthesia. Literature mentions the catheter reduces the CSF leak and sealing of the dural puncture is better. Also, obese patients have less CSF volume and elevated intra-abdominal pressure secondary to large panels. This itself reduces CSF leak and thus they have less tendency to PDPH. There are many challenges which are encountered during spinal or CSE, and these can be reduced by proper positioning. Sitting position is recommended in all obese parturients as compared to lateral. Adequate staffing should be there to support the patient and give optimum position. Sitting position facilitates identification of midline, and distance from skin to epidural space is less in sitting. And excess fat, if at all it is coming in way, can be taped like this in patients. Ultrasound, if available, should be used for identification of midline, level and optimal space. Also, estimation of depth of epidural space is easier. Paramedian sagittal oblique plane is recommended in obese parturients. Extra long needles are available and can be used. However, literature has mentioned that 90% of the obese patients, standard length needles are successful and they are easier to manipulate, provide better control. And hence, they have recommended that it is better to start with the standard length needle and switching to longer needle only if needed. It is required mostly in excessively morbid obese patients with BMI of more than 45. General anesthesia, difficult airway preparedness is absolutely essential. Always call for experienced and additional hands, as fatigue may set in with difficult mask ventilation. Always use the specialized pillows or ramp or towel pads to give like this ramp position in order to avoid the obstruction and also to align the laryngeal view. Difficult airway card preparedness, which should include variety of masks, airways, stubby handle, videolaryngoscope, FLUVA, bougie, and laryngeal mask airway with gastric drainage, that is the Procil LMA and intubating LMA, are absolutely essential. Flexible fiber optic emergency cricothyrotomicin and high flow oxygen delivery equipments like Thrive, HFNC, and jet ventilation should be kept ready. Optimum pre-oxygenation is very essential to reach the target end-tidal oxygen level of 95%, and rapid sequence induction and intubation with the standard agents can be done. However, if the first attempt at intubation fails, second attempt has to be done by an experienced anesthesiologist with all best possible available gadgets, or opt for supraglottic devices, that is Procil LMA, which has been reported as a very successful rescue technique in obese parturients. However, during all this while, no desaturation should be maintained, and this can be done by using supplemental oxygenation during apnea, using either a nasal cannula 15 liters oxygen or using Thrive. IDA guidelines for unanticipated or anticipated difficult tracheal intubation in obstetric has to be strictly followed, and they also stress on using the supraglottic devices with a gastric drainage as the rescue technique in obstetrics, and also no desaturation with high oxygen flow has to be maintained during all the procedures and during apnea. Intraoperatively, to improve oxygenation, PEEP can be added, and extubation should be always in fully awake, pain-free, and semi-sitting position. Multimodal analgesia technique is recommended for optimum postoperative analgesia, which may include variety of drugs and regional. These patients are prone for postoperative pulmonary complications, hypoxemia, pneumonia, and optimum pain control, physiotherapy, incentive spirometry, and also CPAP may be required in certain number of patients. These patients, even myocardial infarction, arrhythmias is common, and hence monitoring in HDU and pulmonary embolism, for pulmonary embolism, thromboprophylaxis, early ambulation, optimum glycemic control is essential. So HDU monitoring and early treatment and prevention of complications is essential for the best possible outcome in these patients. Thus, to conclude, morbidly obese parturients, they have compounded risk and pose significant challenges. Additional experience, help, and multidisciplinary approach is necessary. Adequate optimization, early labor analgesia is indicated, and CSE is the technique of choice for cesarean section with absolute preparation for GA and difficult intubation management. Always have backup alternative plan and prepared to conduct the backup plans. Ensure appropriate post-operative care. Thank you very much. These are few references. Thank you.
Thank you, Dr. Meenal, for an excellent presentation. I think we will go on for discussion for some time because the further Nissan is released. The National IIT office bearers have yet to join. So can we discuss it anytime? Can we go ahead with discussion? Madam,
Yes, Dr. Meenal, it was a very good. Hello?
Yes, madam. Thank you.
It was a very good discussion. I just wanted to know, this patient had another compounding problem.
Yes.
Am I heard well?
Yes, madam.
Yes, ma'am.
The patient was COVID positive.
Yes, madam.
So I just was interested in knowing what was the extent of the COVID pulmonary involvement.
Yes, madam. This was during the second wave of COVID, and when we first saw the patient, even we were clueless whether the low saturation was only due to the obesity and OSA or it was due to the COVID lung involvement. But however, CT and X-ray was not done. In the post-operative period, she required the continued CPAP and other management, and then we did her CT scan, but her lung score was not as bad. They were around, CORAD was 8, and she was manageable, but her problem was compounded mainly due to obesity.
And what was about thromboprophylaxis?
Yes, madam. The low molecular weight heparin was started
before surgery.
No, it was not, madam. Patient was admitted on the same day and was taken in view of fetal distress immediately. So it was not given. It was not possible to give before.
So please explain how, if the patient is, because such patients, even high risk obstetric patients, can be on prophylactic thromboprophylaxis, and if they come for emergency cesarean, then we have to follow a certain protocol. So can you explain it to our listeners?
Yes, madam. The ASRA guidelines are very clear, and we can follow that. That if patients during antenatal assessment, if there are any evidence of deep vein thrombosis, we can do a venous Doppler in high-risk patients or those who have calf tenderness or breathlessness. If there is already evidence of DVT, we may start the pharmacological prophylaxis right from the preoperative period, and accordingly, patient may go in for either vaginal delivery or this is if they are going for operative delivery, we need to give a break and then stop it and then again resume it according to the guidelines. However, if patient does not have overt venous thrombosis or any other complication, only a mechanical maybe a stocking journal that is indicated in the preoperative period, and post-operatively according to the how the patient behaves in drop, if there is excessive blood loss, patient is not going to be ambulated for some time in the post-op period, then again the pharmacologic may be instituted.
Yeah, right. And one more important thing is, what was the consent that you had taken from this patient when the patient proceeded with the, because it is extremely important. See, the obese patients can come out with so many complications. And nowadays, with increasing chances of litigation,
Yes.
it is extremely essential how much and how far you explain to the patient or patient's relatives about the possibility of complications.
Yes, madam. We took informed, written, valid consent and complications related to the surgery itself, the patient's procedural condition, which included the obesity and all the comorbidities. She had PIH on 2 drugs she was on. Then she had gestational diabetes mellitus with highly uncontrolled sugars. So COVID also added to uncontrolled sugar. It was absolutely difficult to control her sugars even in the post-operative period, and it has been documented in COVID. So we took the consent related to all these comorbidities that they may escalate and cause the bad perioperative outcome. So another thing, we took consent related to the technique of anesthesia, that for our first choice is definitely the regional, and we are trying that. However, due to technical difficulty or any other problem, we may have to go in for GA, and the high risk in view of difficult airway, post-operative ICU care and ventilatory support was also explained. Even we had explained the life-threatening perioperative complications to these patients, and even COVID-related complications. So we had taken all these points in the consent.
In the chat box, there is a question for you. If the patient comes with fetal distress, even then, would you go ahead with CSE or a simple spinal?
Yes, madam, we would definitely go ahead with CSE, because many a times we have observed, if we discuss actual problems and everything with the obstetrician, the time actually taken, to shift the patient from actually diagnosed fetal distress, shift the patient to OT, on table, and actually do. And in that, if we plan regional technique, it will add on only 3 minutes more maximum.
Right.
So definitely that is not going to change. In fact, it is going to improve the perioperative outcome. So we definitely, in case if there is any particular reason wherein we just cannot, then we may go ahead for GI. Otherwise, yes, even in emergency and fetal distress, we go ahead. In fact, in obese patients, needle through needle CSE has been documented to be very quick and easier technique rather than the spinal, which is challenging.
Now, I just want your opinion on one thing. In CSE, we don't prove that the epidural catheter is in the place, right? Because we give the spinal and the reaction comes.
Yes.
So,
Yes.
how can you circumvent this problem? Because sometimes if the catheter is not in the epidural space, and when you want to extend the level, it's very true that it should be a combined technique, no doubt about it, because then we can titrate the level. But how can you go about it? I mean, is there
Yes,
any
madam.
other technique?
Luckily, we have not faced it in this patient or any other patient we have used, and most of the times with our the initial spinal and only one graded top up we could able to manage. However, since test dose is not given initially at the big placement, but before any top up, we definitely give a test dose to confirm the correct positioning and to rule out any malposition of the catheter, and then we go ahead. But if at all, if it is not working and the duration is extending, we may have to think of supplementing with other.
They have described one more technique, that is DPE, I think. Am I right? Is it DPE? There is a puncture of the epidural space. Dose is not given spinally, and then
Yes.
like CSE only.
Yes, usually it is used in the labor analgesia, madam, wherein wherein we actually just give a puncture, and we use the epidural catheter only and do not give any drug through the However, for cesarean section, we would prefer definitely a low dose spinal, so as to have a fast, immediate onset, and then.
Right, absolutely true. Because even in CSE, we are going in the needle to needle. So actually, we are assured that the catheter is in the epidural space. Anyway, that I wanted you to discuss that particular technique. That's why I asked you this question. Thank you.
Thank you, madam.
Any other questions? I think there were few in the chat box. One I could read.
If I can comment a little on madam's presentation.
Yes, sir. Please.
My compliments to Dr. Herde. You did an excellent job and you hardly left anything for the moderators to talk on. Point is, a time has come where in municipal hospital also now we have started getting obese patients. It is not that they were coming only in higher centers or private practice, but they are now coming even in municipal hospitals, and it is becoming quite frequent and quite difficult because there are at least Nair hospital is very well equipped, but the peripheral hospitals where I work, the word advanced laryngoscopes and bronchoscopes and all is not to be commented on. So it's not easy to manage this case in private. Another thing that happens is the trouble starts from the IV line. The trouble starts from the conical arm that they have where the BP instrument is not going to fit. There are so many different, our tables are not suitable for them. The shifting trolleys are not suitable. I did just a couple of weeks back 138 kg or something, 38 BMI. But as you rightly said, long spinal needle is not required. Only once I had to nick the skin a little because I was entering the space, but that skin was throwing my needle back. So eventually, then the flow will stop. The moment I leave that needle, the flow will stop. So I nicked the skin a little and managed to push my needle about half centimeter inside. So that's the only time in so many efforts that I have not been able to do with a standard needle. The standard needle is good enough. So as the neck is concerned, invariably it is not so difficult. All the obesity is below this line. So this part is nice and clear, invariably. Even for my routine bariatric surgeries that I see, we rarely find that neck. Though that we see, of course, when you cross BMI of 50s and all those things, where you see a patient of 252 kg and when there is hardly any neck and everything is folded and folded and folded. But invariably in parturients, we don't luckily see. They are quite young. They are not yet reached that stage. But otherwise, very nicely done. Of course, stockings are absolutely mandatory. And CSC, yes, as Dr. Palikawal said, it does take little longer time, but if it is possible to give, nothing like it. Because we do not know how the closure will take place. It is not easy to close that abdomen. There are layers and layers upon of fat over there. Very nicely done. Thank you very much. All the best to you.
Thank you, sir. Thank you very much.
Anita, please discuss the questions in the chat box. Dr.
Yes. Actually, so Bhatt sir and Kelkar madam, there is a question that though there is fetal distress, so you feel that still you should go for combined spinal epidural, though there is a fetal distress, because it might help in the closure and it might take long. Sir, you are muted. But sir.
It will be ideal to put a CSC, but believe me, you cannot feel anything on the back. You are not going to get ultrasound machine and you are not going to on the spot diagnose it. इतने में तो आप खोल के एक बार शायद डाल दे ना epidural. Because when you cannot even locate that space, you have to just blindly, as Dr. Bala Venkat puts, posterior superior iliac spine, put that needle and then the needle cover on the top it and go blindly inside. You will hit the mark that you want. I have successfully done that, as Dr. Bala Venkat has very rightly said, So if you cannot feel that, you have to try that technique. It really goes. A simple spinal, little additional buprogesic that I like to put. It gives me half an hour extra of anesthesia. And I have not gone for CSC. No, never. It's not that easy because number one, it is not going to be easy to acquire a CSC set in private. So I have to then give sequential one level epidural, one level spinal and all. So that again is not going to be of much use. So simple spinal and of course in private, the surgeons are also, they understand many other things also. It's not that they are trainees and all, they really work fast, Of course, but I've seen people working in my Shatabdi hospital, they finish 625 minutes also. So yeah, it's not that in private they are faster, but in institutions also they are very efficient and very fast people. So time is not a real constraint. It really does a good job over there. But yes, you have to keep in mind that if it doesn't work, then what? So CSC is a good technique, but on paper, I would go for a simple, straightforward spinal. As Dr. Herde said, again, standard dose, or don't reduce the dose with the fear that it will give lesser, because if that anesthesia becomes little lesser, you are in deeper trouble. I would rather give a full dose and then give ramp position to control my level.
So how much bupivacaine would you like to give, sir? Because as obese patients, we want to give lesser dose.
Yes, sir, means normally I give 2.2 ml, but in this case I will still give 2 ml, at least if not 2.2. If it's real short, then maybe 2.2. Otherwise 2.2 I'll still go for.
So
I'll
Dr.
accept little higher level.
Yeah, Dr. Minal said that she would like to reduce the dose by 25%. So that is over and above, because as it is, you give half the dose of bupivacaine in for
No,
the
Dr.
LACS.
Dr. Meenal said that even she would like to use the full dose.
Yes, yes. I have mentioned it has been mentioned that 25% reduction. However, dose need not to be reduced. You just have to limit the kephaloid spread.
That's right. Just give the ramp position does the job.
There is another question in the chat box.
Yes.
LMW is given. What will be our stand for fetal distress if there is a fetal distress in posted for cesarean section? Hello.
Yes.
Yeah, I heard that question, but somehow invariably we have not seen patients who are getting low molecular weight heparin because they are basically mobile. They really do not get that thromboembolic events. And if they are getting it, and then of course the whole line of treatment is going to shift totally. I would rather go for a general anesthesia straight away. And doing bariatric surgeries every day, we are not bothered about giving GA. We are used to it. But still, cesarean section, multiple problems, and madam's patient was lucky to have COVID also, a real challenge. Nobody wants to go near that patient, and she had to anesthetize that patient. That itself were very creditable and a big thing.
Yes, it's really
So
difficult.
if the patient is receiving low molecular weight heparin, we just have to check when the last dose was given.
Yes.
Yeah, that is.
And depending on that, you can decide about whether to give a regional or not.
Madam, can we straight away give spinal anesthesia with a Whitaker 25 needle? An experienced
Yes, yes.
anesthesiologist giving a single shot spinal anesthesia
That is
is
true.
unlikely
Yes,
to
yes.
cause any problems. Rather than giving an epidural, I would still go ahead with a spinal. If the risk versus benefit analysis shows me that giving GA in an unfasted obese patient in the middle of the night when I'm doing the case alone in a small nursing home, I would like to stick to spinal anesthesia.
I agree with you.
I agree with
Only
sir.
thing is we will have to monitor the patient very closely after the
Yes.
surgery, and we have to, whichever nursing home it may be, but we have to make the nursing home staff aware of
Yeah.
checking the return of the power to the lower limbs.
Yes.
No, obstetrician are giving. Obstetricians are now giving regularly the LMW in many patients.
Yeah,
Yes.
that's true.
One more point I wanted to make, Dr. Meenal Herde, you said about the preoperative assessment. Now, suppose this patient would have come for a private practice labor analgesia. I would like to make a point that we may end up doing the pre-op assessment about the airway when the patient came to me first. But now the labor has progressed. Okay, I've given an epidural. I'm conducting the labor analgesia. It has acted very well. She is now going for a cesarean section because suddenly the fetal heart rates have dropped. The point here is that all of us should understand that we must do the airway assessment again on the table, because here after 4 hours she's a pre-eclamptic patient on antihypertensive, there is edema, the airway can change dramatically. So your PAC which you have done about the preoperative airway assessment may not hold true. So just remember to do one more preoperative assessment, Malampatti scoring, check your MPC 4, 3, 2, 1, keep your plan ABCD ready, ask for a help, and then induce the case.
Yes. How? Hello. How
See,
routinely?
the practice of asking for help should become more common, because tackling such cases independently, it is always better to have expert help, if required, because if you have to do the intubation, it is always better to have some
Yogin
help.
sir, in your practice, I am sure you will have 2 anesthetists for such a case.
I always have 2 anesthetists for every case that I have.
Perfect.
Welcome, Dr. Navin Malhotra. We are very happy to have you with us on the board of Maharashtra. And I can't agree less with Hemant, because in private practice, I have always mentioned in all conferences, in private practice, there is only one indication of general anesthesia for cesarean section, and that is second failed spinal.
Okay.
Because in the middle of the night, you are not going to get any help. You are not going to get manpower and material power, nothing you are going to get, and you will be stuck like anything. Even if the patient is having an acute eclamptic fit at that time, yet in private practice, small nursing home practice, this still remains choice of anesthesia for most of us who are practicing solely in small nursing homes.
How routinely, sir, you do echocardiography in these obese patients? Hello?
It is not really done routinely. No, I don't think so. Dr. Hemant, do you recommend that?
See, Dr. Yogen, I know where Avinash is going. Yeah, routinely, see, in an emergency, it would be very difficult, again, depending upon the setup. Now, she did the case in Nair Hospital where you can get everything under the
You can get
sun.
everything, yes.
Yes, but you and me, like Yogen sir and me, if we are not working in a tertiary care on that particular day and this case comes, it's very difficult for us to get a 2D echo done. But if she complains of breathlessness, it is better you go ahead and get it done. But again, in emergency, it's going to be very difficult to get a cardiologist who will do a 2D echo. So but again, your HOCMs and all are extremely common in these patients, and you may land up in problem later on. So you got to be very careful. Your clinical assessment has to be very good, and well, 2,
Most
3
of the
as many
obstetricians,
hands.
most of the
And leave
obstetricians
aside
do
CT
it
distress,
in
but
ANC period.
when the patient has been referred, you must ask for 2D
Yeah.
echo. And
Yes.
this cardiomyopathy consent also, that's what I meant to ask Dr. Meenal, that also has to be explained to the patient. Even though not frightening, in the frightening work, but we have to inform the patient what all possible complications can take place.
And the setup has to be very, very good. Again, I am saying this. Please don't do these cases in a small place. Transfer the case to a tertiary care center or transfer everything like your manpower help and the work. Everything should be ready in that setup, and then only you can do this case in that setup. Manisha madam, our guests are waiting.
Yes, yes. We can actually carry on the discussion after the second case.
About to say the same because our respected dignitaries, National ISA President Dr. Venkatgiri and Secretary Dr. Navin Malhotra sir and our own Vice President Dr. Anjali Bhure has already logged in. So let us begin with the program of Maharashtra State Chapter ISA MSCISA, that is a newsletter. That is the first issue of our academy, our tenure, that is going to get released today with the hands of all National ISA dignitaries. May I request Dr. Maya Bhalerao madam to continue with the program?
Yes, yes.
Maya madam.
Yeah. Good evening, all of you. Can you hear me?
Yes, madam.
Yes, madam, but there is a problem in voice and your slide also.
Slide Mr. Abhijit has shared, and my voice is clear or not?
Voice is
There is a
also.
slight echo actually, Dr. Maya.
Yes.
Echo to your voice.
Voice is not clear.
Have you logged in from 2 devices, Hi, madam? If you have logged in from 2 devices, please leave from one.
Sorry to interrupt, but I will request everybody else to please mute their mics and Maya ma'am then try once.
Yeah.
Hello. Can you hear me clearly now? Hello.
Yes.
Still there is a disturbance.
There is some disturbance
because I have logged in from only one device.
There is a background issue from someone else's mic, so requesting you to please turn off their mics, please.
It's okay now?
Yes, ma'am,
it's okay.
Perfectly fine.
Please go ahead, madam.
Yeah. On behalf of MSCISA, I, Dr. Maya Bhalerao, President, ISA Pimpri Chinchwad, take the opportunity to welcome you all in the release program of inaugural issue of MISA News. It's a great pleasure to have ISA national dignitaries on the digital dais today. A very warm and cordial welcome to respected Dr. Venkatgiri Sir, President ISA National, Dr. Anjali Bhure Madam, Vice President ISA National, Dr. Naveen Malhotra Sir, Honorary Secretary ISA National. A warm welcome to MSCISA Office Bearers, Dr. Manisha Katikar, President, Dr. Anita Nehte, Vice President, Dr. H.K. Sare Sir, President-elect, Dr. Avinash Bhosle, Honorary Secretary, Dr. Samir Sohoni, Honorary Treasurer, and today's celebrity, Dr. Hemant Shinde as an editor. I welcome respected Kalpana Kelkar Madam and Dr. Yogen Bhatt Sir also. A warm welcome to all delegates. Any auspicious program always commences with a lamp lighting ceremony. So I invite all the dignitaries to join for Deepa Prajulan on virtual platform. Mr. Akhilesh, please lamp lighting ceremony. Video, please. Sound. Lamp light symbolizes knowledge, wisdom, and truth. Tamaso ma jyotirgamaya, which means we have to move from darkness to light. Knowledge is the everlasting inner well by which all our outer achievements can be accomplished. Hence, we light up the lamp to bow down to the knowledge as greatest form of wealth. A single lamp can light 100 more, just as a man can enlighten and give us the knowledge to many more. And so today, so true today for our MISA news also. Thank you all dignitaries. Friends, COVID had changed our lifestyle and we humans have adapted the changes very quickly. In the COVID pandemic, apart from COVID duties, MSCISA members are participating in activities organized by MSCISA, may it be an academic activity or non-academic activity like Diwali celebration or Sankranti celebration. Recently, we had a Sankranti celebration. I request Akhilesh to play a small video about our Sankranti celebration. Akhilesh, can we have a sound, please? Akhilesh? Thank you, Akhilesh. This Diwali celebration or the Sankranti celebration is happening because of our ever enthusiastic, ever charming President, Dr. Manisha Katikar and her entire team. She is the founder, editor of MISA News. And this MISA News was first time published in 2008. The glorious journey of MISA News goes on since then. The legacy is well carried by various able editors. And now, Dr. Hemant Shinde, a multifaceted, multi-talented Parsana has taken the responsibility as the editor of MISA News this year. I request all the dignitaries to have the release program of our MISA News. Dr. Naveen Malhotra sir, Dr. Venkat Giri sir, Dr. Anjali Bhure madam, and MSCISA office bearers, please join hands for the release of the MISA News virtually. Akhilesh, can you scroll the MISA News copy? Yes, yes. Thank you so much. You can go ahead, Akhilesh. You just scroll it. Yeah, thank you.
Akhilesh, can you have some music here?
Music, I think.
Have you added
Akhilesh, can we have a sound also? I think sound is also very low.
Okay, it's finished now.
Maya madam, we will continue with further program.
Yeah,
okay.
Thank you, ISA national dignitaries for this release. And this is a fantastic creation. This is a really challenging task to organize such a huge data so meticulously with a great.
Hello, Maya?
Yeah, thank you, ISA national dignitaries. Thank you so much. It was a really fantastic compilation, and it must be a challenging task to organize such a huge data so meticulously. With a great pleasure, I invite Dr. Shinde to unwind this journey of compilation of MISA News. Over to you, sir.
Thank you so much for that, Maya madam. Thank you. And yes, I have become the MISA News editor for these next 2 years. And it's a fascinating journey, as you rightly mentioned. I have difficult shoes to fill in because our previous editors have been Dr. Katikar madam, Dr. Anita madam, and so many of them. They have done a wonderful job since 2008. About this particular issue, this is the first issue of the MISA News, and when we decided, we had an extensive discussion with Katikar madam as well as Anita as well as our secretary Avinash Bosle, and we decided to come out with a non-academic issue. The first issue being non-academic, we were a little skeptical, and the theme then we decided was to go for the VAT celebrations. As we know that the job of MISA News is academic as well as non-academic, but we need to percolate the schemes of National ISA, which is doing a great job under the leadership of Venkat Giri sir as well as Naveen Malhotra sir. And it is coming down. We had to spread it across to the Maharashtra state last members. We've got 32 branches. 22 of them are extremely active. And we've shown that, Maharashtra state has shown that in coming as #1 state in the various categories and overall state, #1 state in the annual conference. So we wanted the healthy competition to continue. This year we have got 78 prizes. We would definitely want to reach the 3-figure mark next year. So to create this healthy atmosphere, a competition amongst ourselves, we decided to come out with this VAT issue whereby we will have celebrations also included in it, And under the various categories, whosoever has won something or the other, we've tried to include all those data and why they have won, under what category, which will stimulate further people to apply and to do things for the next year. Having said that, I would also like to say a certain thing about one particular promise I still remember I had made from Nagpur. Like, we've got plethora of seniors with us. Right now also we've got Kelkar madam sitting with us with phenomenal amount of experience. Now they are our heritage, they are our past as well as present, and they will also be our future. But how many of our juniors really know about the amount of work they have done? So I have included one such person this time in this particular issue. Now this was Dr. Bhojraj. Dr. Bhojraj, sir, I had the pleasure of working with him in Bombay Hospital for a brief stint. I had it in 1990. Now, sir has done phenomenal work. So his daughter is also an anesthesiologist who has written about him. Now, sir is no more. This would have been his 102nd birth centenary this year. So the data has been included in this particular MSCISA news, and I want to do it for our various seniors. I would like the members to come out with a particular junior writing about the senior person and their contribution to the faculty of anesthesiology in the future issues also I would like to include. And one more thing I would like to talk about the future issues. The next issue will be about complications in anesthesia. Now, anesthesia is a science. In science, we don't restrict our data, we don't withhold our facts, we share our facts. So with the amount of members we have in Maharashtra state, I'm requesting all of you to send the complications which you have seen, which you have managed. What was your plan? What was the case? A brief history. What were the investigations? What did you plan? What did you do? How it went wrong? And then what did you do to make it right? Even if it is an unfavorable outcome, I'll see to it that your name doesn't come anywhere. If you want to keep it a secret, we will not give you a name, but at least learn from our own mistakes. That would save many more lives. I wish you all a very happy, healthy, and prosperous and a very safe new year, because this is the first meeting probably in the new year. And I stop at this moment, and kindly help me in future. Thank you very much.
Thank you, sir. Thank you so much. And we should congratulate you as an editor, Dr. Manisha madam as a president, Dr. Avinash Bhosle, Dr. Anita, all MSCISA office bearers. And I would like to have a clap. And Akhilesh, can you please share the slide? Yes, and Shinde sir, you have rightly mentioned that we should reach to the roots. Basically, each and every member should contribute to this MSCISA news, and we will definitely try. And you have a great leadership with this all MSCISA office bearers, and you are going to have a great issues ahead. And you know, any bulletin is the voice of our co-colleagues. It not only reflects the creativity, talent, but it connects the people, as you have already said, and it bridges the gap. It minimizes the gap between the organization and its members. So definitely this MSCISA news is going to reduce the gap. Thank you so much. And once again, heartiest congratulations to all MSCISA office bearers and MSCISA news team. Thank you so much. And most probably, I think within a day or two, this bulletin will be in our hands, in our email and WhatsApp. And do let us know the feedback so that Dr. Shinde will have a better and better issues in coming years, coming months. Thank you, sir. Now I invite Dr. Manisha Katikar, our dynamic, beloved president of Maharashtra State Chapter, to say a few words. And I'm sure the MSCISA news is her baby, and it is very close to her heart. So let's listen from her what she says about the MSCISA news. Over to you, madam.
Thank you, Maya, madam. Yes, as you said correctly, MISA News is a baby that is born when I was made the founder editor of MISA News. So I was welcome the respected dignitaries, respected National ISA President, Dr. Venkat Giri sir, Vice President, Dr. Anjali Bhure Madam, Secretary, Dr. Naveen Malhotra sir. We are missing Dr. Ashok Deshpande sir, as he was not able to join because of some family issues. Respected all Maharashtra State Chapter ISA dignitaries, I must say that Dais of Maharashtra State Chapter ISA is honored and humbled by the esteemed presence of all national ISA dignitaries. Today is the 13th birthday of MISA News. As a president of Maharashtra State Chapter ISA, I am overwhelmed today. The baby of MISA News was born in 2008. Past president, respected Dr. Dilip Paramspe sir, was the mastermind behind the beginning of MISA News. I, being the founder editor, was engrossed in developing, nurturing this baby till it was 4 years old. Then it was handed over in the safe hands of Dr. Charita Gadkari. Gadkari madam continued further care, and then it was our vice president, Dr. Anita Nete madam, who took over of that. In Dr. Anita Nete's madam's tenure, the print issue was converted to e-MISA News, and the baby was further nurtured as e-MISA News in her tenure. Growth further continued in the tenure of Dr. Shubhangi Kothari madam. So I have seen MISA News growing in leaps and bounds over the span of 13 years. And now, Dr. Hemant Shinde at the helm of MISA News, I am sure that this newsletter will be converted to journal in the coming year. We are arranging academic activities every month. Let it be master class or the interactive sessions like this. I request all the members to be a part of this, and if you are interested to join, please let us know. Long live Maharashtra State Chapter ISA, long live ISA. Thank you so much.
Thank you, Dr. Manisha. It is really a proud moment for you as well as for all of us, and we are proud of you. Thank you so much. Now, I request Dr. Naveen Malhotra sir, the great leader of all anesthesiologists of the country, who is instrumental in taking the ISA national at higher level. Sir has inspired many minds and ignited many souls in their life. Sir is a versatile, iconic figure and having lots of bubbling enthusiasm and ideas. He is a hardworking, strategic planner and believes in teamwork. He always inspires us. Sir, we would like to listen from you about our MISA News and about our MSCISA. Over to you, sir.
Thank you, the Master of Ceremony, Dr. Maya Bhalerao, for such nice words. I know you are a multifaceted, multi-talented personality, and hats off to you. The shining star of today, Dr. Hemant Shinde, the editor of MISA News. It's today is 21st January, 3 weeks of the new year, and it's a hat trick of visit to Maharashtra virtually. It's a third consecutive week that some or the other program, starting with the Karad CME, then Thane CME, and today the MISA News release. So back to back in 3 weeks, 3 online participations for the Maharashtra State Chapter, and this speaks itself, which Dr. Hemant Shinde was talking about, the 3-figure target, which I have already given for the Maharashtra State Chapter, that they should vouch for it and really deserve it. I extend greetings from chilly atmosphere of Rohtak at the ISA National Secretariat, and I'm really envious of Dr. Avinash Bhosle, where I can see the fan is in his background, and I'm having heater and just took over my cap also. So that's the versatility of our country, but that's the beauty of it. Dear Dr. Venkat Giri, President ISA National, very respected Dr. Anjali Bhure, Vice President, and the office bearers of ISA Maharashtra State Chapter, Dr. Manisha Katekar. I never knew, today I came to know that it's your baby and you have been the inaugural editor of MISA News. That speaks of your multifaceted personality in both academic, clinical, and research fields. Salutes to you, ma'am. and you are ably supported by very nice team of Dr. Anita Nete, Dr. Saleh sir, Dr. Vinash Bhosle, Dr. Samir Sohani, and definitely Dr. Hemant Shinde. And also our own Dr. Anjali Bhure madam, who is Vice President, and Dr. Deshpande. They're all there to support you. So it's Dr. Hemant Shinde. Today is very auspicious day. Today is Sakat Chauth, the Ganesh Chaturthi or Sakat Chaturthi.
Yes.
In our part, it is celebrated with lots of fanfare. It's a very auspicious day where parents keep fast for the well-being of their children, and they don't take a sip of water throughout the day. And today you are releasing your inaugural issue on this very auspicious day. I am very sure MSCISA News will soon be and develop from e-newsletter to a journal, because the works which are done with good intent and started on auspicious day, definitely they bear good results. And I'm really happy that I'm here witnessing this release. Yes, when I was in Pimpri Chinchwad on 5th January 2019, I happened to meet Dr. Shubhangi Kothari also, and she was also very passionate about MSCISA News. So I'm very sure you will carry on the legacy of the editors and take it as the holistic issues. And your theme of the inaugural issue is very, very nice. And of the upcoming issue on complications is also excellent. So I congratulate all the team members of ISA MSc from ISA National on the release of MSCISA News and on its 13th birthday. So it's becoming a teenager now. And I know, I'm very sure it will be soon a full-fledged adult journal and taking care of the academics, clinics, and research. I'm thankful for inviting me here. Long live ISA, Jai ISCN, Jai Hind. Thank you very much.
Thank you, sir. Sir, thank you so much for your kind words, your blessings, and your motivation to all of us. Thank you so much. We are really very lucky to have you as our ISA National Honorary Secretary. Thank you so much, sir. It's really a proud feeling when we meet and we see our dear leader and Vice President, ISA National, Dr. Anjali Bhure madam. She's a very charming, friendly, and humble person. And I feel whenever she is there with me, I feel I'm with my elder sister or I'm with my very close friend. Thank you, madam, for giving us that feeling. Thank you so much. And it's our honor to have your comments and compliments or maybe some your opinion about MSCISA News. Over to you, madam. Anjali Bhure, madam. Madam, unmute yourself.
She is saying that she is unable to unmute herself. So the somebody has to allow her to unmute.
Yeah,
Yes, madam. Yes.
Thank you.
Yeah,
thank you, Maya. A pleasant evening to all the attendees. Honorable President Dr. Venkat Giri sir, Honorary Secretary, our own Dr. Naveen Malhotra sir, Office Bearers of Maharashtra State Chapter ISA, Dr. Manisha Katikar madam, Anita Nete ma'am, Dr. Saleh sir, Dr. Avinash Bhosle, Dr. Samir Sohani, and today's star, Dr. Hemant Shinde, Editor MSCISA News, Kalpana Kelkar ma'am, and Yogen Bhatt sir. I would like to compliment all who were and are part of MSCISA News for their dedication and commitment, and also for taking this newsletter so high. It is great pleasure to celebrate the release of first issue of this tenure under the able leadership of Dr. Hemant Shinde, whose very enthusiastic and dynamic personality, our editor MSCISA News. Contribution of the members in MSCISA News in academic field, highlighting the major events, achievements, has made this newsletter a very popular one in our state. So heartiest congratulations, Dr. Hemant Shinde sir, for a bright beginning, and wishing a rewarding success to Dr. Manisha Katikar and her team for their future endeavors. Thanking you for inviting me to join you today on 13th happy birthday of MSCISA News. Long live ISA, long live ISCN. Thank you very much.
Thank you, Anjali madam, for such a nice words. Thank you so much. Friends, The moments are always cherished when you are blessed with good wishes from the supreme authorities. I remember when we had release of our Pimpri-Chinchwad bulletin last month, for the very first time, we had received message with a personal names. And I was very much elated. And that message was from the man who has a clear vision. He is a dynamic persona. He is approachable, he is assertive, and he is proactive. Yes, I'm talking about none other than our beloved President, ISA National, respected Venkat Giri sir. I request sir to address the August gathering with presidential speech. Over to you, Venkat Giri sir.
President of today's meeting, Dr. Manisha Katikar, National Vice President, Dr. Anjali Bure, Secretary, Dr. Naveen, Dr. Deshpande, GC member in his absentia, office bearers of ISA Maharashtra, dear friends, compiler and MC Dr. Maya, editor Dr. Shinde, and all friends in Maharashtra. Namaste. I'm happy to participate in this release of the inaugural issue of this year's MISA News. It is 13-year-old. Yes, it was, as I heard that it was earlier print, then became E. Now there is a demand that it should become a Naveen telling full-fledged journal. With so much activity, I was thinking one step further, why don't you start Western Zone Journal? Because we have already started zone journals. And I think definitely you should, with so much academics and all, make it very active and start the Western Zone Journal, which is not started because Central Zone and North Zone have already started and South Zone is on its way. And I think you should start that with this. And as Dr. Shinde told, this is topic based or some every issue this time is non-anesthesia, next time complication like that. That's good that people can have reading that. More than that, what I feel is that individual or case management for private practitioners, because how Dr. Yogen Bhatt was telling and addition was there by Dr. Shinde and all, how we manage the cases different in different places. He was explaining. And I think the journal should contain that also, so that the common practitioners will know that what we read in textbooks is ideal for the medical college and ideal setup. All are not that privileged to work in the medical college or in the ideal setup. We have to work in the periphery. Though whatever they say that we have this and all, we should have the minimum. Though we should have the optimum or the best amount, we should have the minimum. We should be able to do in the minimum the best service which we can give. See, when I studied, there was no monitor, only hand on pulse. And now that now even a junior comes, he is not able to manage the case without a workstation or without a multi-para monitors. Hand on pulse is not there. Clinical, we should tell that also. That's always that machine can fail, but we should not fail. We should be there. So that also should be there. Plus, as you said, that non-anesthesia topics we have to teach. I always tell in our meeting that we should know how to live this life. It is not only giving anesthesia, other things. Okay, family life, then crisis management, all this should be. Maybe with the good article with that, it will be very, very popular. I wish all the best for this. And thank you once again for inviting me. And as Naveen told, this is also mine also third consecutive presence in this thing. Maybe I would have attended because I remember personally attending in different places in Maharashtra during my secretaryship and attending you all. I remember Dr. Maya's place coming there and attending that, then Pune. Maybe if it allows, after some time, I will again start journey and visit you all personally, and it will be enjoyable. Thank you once again. All the best.
Thank you so much, sir. And you are most welcome in Pimpri-Chinchwad city, in Maharashtra, at different places. And our president has planned so many programs, and there are so many events. So you are going to definitely come frequently and visit us and bless us. Thank you so much. Now it's time to say bid adieu. I take the opportunity to extend my gratitude to ISA national dignitaries, Dr. Venkat Giri sir, Dr. Anjali Bure madam, Dr. Naveen Malhotra sir, for taking out time in their busy schedule and to be with us for this inaugural program. Thank you so much, ISA national dignitaries. Thank you. Actually, Ashok Deshpande sir, we are missing him. Thank you, MSCISA office bearers, Dr. Manisha, Dr. Sare sir, Dr. Anita Nete, Dr. Bhosle, Dr. Samir Sohni, and Dr. Hemant Shinde for giving us such a wonderful issue. Thank you. And thank you, Manisha. Special thanks for giving me the opportunity to be with you all as a part of this event. Thank you all delegates for joining this memorable program. Thank you, Abhijit, for smooth and flawless technical support. And thank you. I hand over this dais to Dr. Manisha Katikar or the MSCISA office bearer for further proceedings. Long live ISA, long live MSCISA, and stay happy, stay healthy, and be in touch with everyone. Thank you so much. And thanks. Abhijit, thank you. Slide once again. Thank you. Thank you. Over to you, Manisha, madam.
Thank you so much, Maya, madam. Thanks a lot for anchoring this session so flawlessly and so nicely. In 2 days, you prepared everything and you are with us, and we really enjoyed your anchoring this function. We will continue with our second clinical case. Teacher madam and Yogan Bhatt sir, we will continue with the second case, and then we will go on for the discussion for both the cases. So may I request Dr. Anushri madam?
Yes, ma'am. I'll share my presentation.
Just wait. Let me... Hello.
I hand over the mic to Dr. Samir Sohni to introduce Dr. Anushri madam.
Thank you, Manisha madam. For this, the second speaker is Dr. Anushri Chaudhary. She is assistant professor from Government Medical College, Meerut. She has done her MBBS, MD Anesthesia, and DMD. She has already have 4 publications in various journals, national and international. She has won many prizes in her career till now. Recently included Teachers Category Award in at our state conference held at Nagpur also. And she is also having extracurricular activities like poetry and sketching. So Maya madam, one more candidate is there from our cultural and art side. So I request Dr. Anushri madam to present her case now. Over to you, Dr. Anushri.
Yes, sir. Thank you very much for the introduction.
Yes, your screen is visible, madam.
Yes, sir.
Yes, your slides are visible.
Yes, sir.
Yes, visible. Please go ahead, madam.
Can you, sir?
Yes, slides are visible, madam.
Yes. First of all, I'm very thankful for giving me this opportunity to present my approach of the anesthetic management of a 55-year-old hypertensive, morbidly obese patient who has been posted for exploratory laparotomy. Obesity, as ma'am has told, has become a global epidemic. Over the last 40 years, the prevalence has increased by 3 times. Worldwide, 650 million adults are obese, whereas in India, 153 million have abdominal obesity, according to an ICMR India B study, which was done in 2015. Morbidly obese patient is a patient with a BMI of more than 35 with comorbid illness, or a BMI of more than 40 without any significant comorbidity. BMI can be measured as weight in kgs upon height in meters square. Recently, a term has been coined, that is obesity paradox. It applies to the class 1 and class 2 obese patients, and it emphasizes the fact that a BMI alone does not put a patient in a high risk category. It is the BMI, higher BMI, associated with comorbid illnesses and airway difficulty, which puts a patient in a high risk category. So we have to understand central and peripheral obesity. The commonly used terms, as we all know, is apple and pear-shaped body. Apple-shaped body, when the fat is located in the abdominal cavity, it is more metabolically active and it contributes to the presence of various comorbid illnesses like cardiovascular diseases, thrombosis, metabolic syndrome. According to WHO, a waist circumference of more than 102 centimeters in male or 90 centimeter in Asian males and 88 centimeters in females or 80 centimeter in Asian females is said to be definition of central obesity. So we have to understand our obese patient, whether the patient is having metabolic syndrome, cardiovascular disease, obstructive sleep apnea, or an OHA, or difficult airway, respiratory diseases, venous thromboembolism, and hyperglycemia. So coming to metabolic syndrome, what is metabolic syndrome? It is nothing but a cluster of conditions which have similar pathophysiology. According to the National Cholesterol Education Program Adult Treatment Panel 3, a definition which is definition is used. It states that if 3 of the following 5 criteria are present, then the patient is said to have metabolic syndrome. Central obesity, along with hypertension, increased fasting triglycerides and fasting blood sugar, and decreased fasting HDL. Now, it is important to know because these patients are having higher risk of post-operative cardiac complications, pulmonary complications. They have poor glycemic control. In fact, most of them are associated with type 2 diabetes, which may lead to post-operative infections in them. Obese patients may have increased blood pressure, or if OSA is untreated, they may have pulmonary hypertension and signs of heart failure. Also, fatty infiltration of the conducting system makes them prone for arrhythmias. Obesity is a prothrombotic state. The patient may be associated with myocardial infarction, stroke, or venous thromboembolism. Venous thromboembolism is 10 times higher in obese women, and the risk extends beyond 2 weeks post-operatively. So we have to be careful in the post-op care too. Patients having perioperative hyperglycemia are more prone to pneumonia, systemic blood infections, urinary tract infections, skin infections, and renal failure. Various studies have been done in which they found that if post-operative day 1, the blood glucose levels are more than 220, the infection rate is 3 to 6 times. Coming to the respiratory system, because of obesity and fat around the different organs, they have reduced functional residual capacity and they are more prone to atelectasis and shunting in the dependent lung regions. But these patients have increased resting metabolic rate, work of breathing, and minute oxygen demand. Now, this combination is very serious, and once there is cessation of breathing, the arterial oxygen levels decrease rapidly as compared to normal patients. Also, they may have airway closure at rest, which we may find as V's. So the red flags are if the saturation on air is less than 95, if PFTs are available and functional FVC and FEV1 in 1 second are decreased, if the patient is having respiratory V's at rest, or in ABG the serum bicarb levels are high, then they are more prone to post-op hypoventilation or desaturation. Now, what is OSA? These patients, because of their fat, they have increased sleep disordered breathing. So if a BMI more than 35 with neck circumference, which is measured at the level of Adam's apple, more than 17 inches or 43 centimeters in male, or 41 centimeters and 16 inches is a female, associated with loud snoring or observed pauses in breathing, or awakening from sleep with choking sensation and frequent daytime somnolence, then the patient is most likely to have OSA. We have a very common stop bank score, which I'll discuss later. Now, why we should find out whether the patient is suffering from OSA? Because they have more chances of postoperative desaturation, respiratory failure. CPAP is very important in them preoperatively and postoperatively. They may have difficulty in airway and laryngoscopy, and they are more sensitive to sedative and opioid-induced respiratory depression. So mostly we should use an opioid sparing technique in them. Now, this OSA may progress to become a obesity hypoventilation syndrome, in which sleep disordered breathing along with obesity is associated with hypercapnia. So they are, again, as I said, have more risk of respiratory arrest post-operatively, or they may have cor pulmonale. So in pre-op evaluation, I'll quickly calculate the height, weight of a patient and calculate the lean body weight. I'll see if the patient is having central obesity, NYHA class of the patient, BP, if patient is having pedal edema, breath holding time. I'll auscultate for V's, note the room air saturation, and I'll see if the patient is having OSA or disordered sleep breathing. In investigations along with hemogram, I'll order RFT, LFTs, triglycerides, HDL, and blood sugar, ECG to see if there's any arrhythmias or STT changes, chest X-ray, ABG to find out bicarb and CO2 levels. If a portable echo is available, it will give me a clue to the LV dysfunction if it's there, and rule out DVT clinically or if a Doppler sonography is at hand. So clinically by tenderness, or if the calf circumference is more, or there is a high level of inactivity in the patient, then I'll be alert. Preoperatively, this is the stop bank score, which correlates with obstructed sleep apnea. So I'll ask the patient if he snores loudly, if he falls asleep during daytime, if anybody has observed him stop his breathing during sleep, if he's having high blood pressure, BMI in more than 35, age more than 50 years, if the neck circumference is high, and if he's a male patient. So my patient is a male patient, more than 50 years, morbidly obese and hypertensive. So already 4 out of 8 are positive. If it's more than 6, then it highly correlates with OSA, moderate to severe OSA. Now coming to the airway assessment. Bag mask ventilation in obese patients correlates with higher BMI, higher age, lack of teeth, snoring, presence of beard, Malampatti class 3 or 4, and jaw protrusion severely limited. That is, the patient is not able to bring his lower incisors in front of the upper incisors, because then jaw thrust will become difficult. Difficult tracheal intubation correlates very well with the neck circumference. Various studies have been done which show that higher the neck circumference, there's higher probability of difficulty in intubation. Also, short neck, that is thyromental distance less than 6, decreased mouth opening, limited head and neck jaw movement, more BMI, and Malampatti more than 3. So in my patient, how I'll assess is, I'll see the Malampatti grading, mouth opening, subluxation, that is patient's able to bring his incisors in front of upper incisors or not, thyromental distance, neck movement, if it's less or more than 90. Then I'll ensure that there are suitable trolley and operating table and table extensions available, gel padding or any kind of padding to prevent the pressure, protect the pressure areas, wide strapping, a large BP cuff, equipment for ramping. I'll ensure there are many sheets to be put in below the shoulder, neck and head. Then if I have a NMT and base, then I'll use them. A monitor which is having a pressure mode is helpful. And I'll use calf compression devices for DVT as prophylaxis. I'll prepare the difficult airway cart and keep different sizes of face mask, handles, blades, McCoy laryngoscope, bougies, especially ventilating bougies and stillets, oropharyngeal, naropharyngeal airway, a nasogastric tube, second generation LMAs, either LMA Supreme or LMA Fast Track or Proceed. Then a AMBU. Video laryngoscope, one available with us is TrueView Evo 2. It is very good because it has an oxygen port through which you can give a continuous oxygen, so the apnea desaturation time decreases. Flexible fiber optic bronchoscope and cricothyroidotomy kit, but if it's not there, then a cannula, scalpel and a smaller ETT. If a airway exchange catheter is available and Thrive, then it's good enough. This is a cart which has been according to the IDA guidelines 2016. So preoperatively, I'll use pre-op bronchodilators if the patient's having V's, a CPAP if he's already using then that, or hospital CPAP, and encourage the patient for self-positioning on operating table. I'll avoid sedatives but consider antacids. I'll plan an epidural anesthesia for intra-op and post-op analgesia. I'll attach the basic monitors and use extra long epidural needles and sonography if it's available, and do the epidural technique in a sitting position. Local anesthetic drug dose I'll use is according to the lean body weight. Now the advantages of regional are, it is a opioid sparing technique. It will help in early ambulation post-operatively as a prophylaxis for venous thromboembolism, and it will aid in better post-operative breathing, intra-op and post-op breathing. The problems are, of course, there may be failure in techniques because of the inadequate needle lengths, but long needles are available, and as we all have discussed, even 8 centimeter needles can be used. Now the position I'll do is ramping. We all know that in obese patients, ramping position is better than the sniffing position, as you can see in the first picture. So the external auditory meatus should come at the level of the sternal notch. Pre-induction, I'll attach the additional monitors of BIS and NMT. I'll pre-oxygenate in 25-degree head-up ramp position, 100% oxygen for 3 minutes tidal volume breathing, or if for 1 minute, then it will be vital capacity 8 breaths, and a target of end tidal oxygen of more than 90. Throughout, I'll use a PEEP of 10 centimeter. Now, the recent new concept is apneic oxygenation using a nasal cannula according to IDA guidelines and other studies. So it further increases the apneic desaturation time to 4 minutes. In that, we have to give 10 liters of oxygen through nose using a nasal cannula, or you can use any other any other catheter. The advantage is it delays the apneic desaturation. Pre-oxygenation may result in atelectasis, so later on we have to use recruitment maneuvers. I'll quickly touch up Thrive. So Thrive is when you use a equipment to give 70 liters per minute of oxygen through nose throughout till you secure the airway. It needs a dedicated equipment, but we have HFNOs nowadays because of COVID, so we can use them. It provides CPAP, prolongs the safe apnea time. Now, I'll induce with a rapid sequence induction. I'll use injection fentanyl 1 microgram per kg of lean body weight, injection propofol 2 mg per kg of lean body weight, injection scoline 1.5 mg per kg of total body weight. I'll quickly start the maintenance. I'll prefer DES. We have it in our setup, but if not available, I'll use SIVO to avoid any accidental awareness. Now, if we calculate the drugs based on total body weight in these patients, the risk of overdose is there, and that is why initial anesthetic doses should be calculated according to lean body weight. But whenever you are in doubt, it is best to titrate and dose to effect, that is loss of eyelash reflexes, nerve stimulator response, or relief of pain. Now, in an obese patient, total body weight correlates with the actual weight. Lean body weight is nothing but there are different formulae available, and this is a very commonly used formula which has been found out in a study published in BJA, BMI into height in meter square, where BMI is taken as 26 in males and 22 in females. So this is the lean body weight of the patient. Now, how I'll proceed? In a RAM position, also called as HELP position, with nasal insufflation in place, and after pre-oxygenation and induction, I'll do a bag mask ventilation. If there is difficulty in mask ventilation, I'll use the two-hand technique or a adequate oral airway. If still it's not possible to ventilate, I'll quickly use the LMA Supreme, which is available with us as the second choice for ventilation. And then I'll apply PEEP throughout. My first attempt at laryngoscopy will be using McCoy 4-size blade. And in RAM position, short handle laryngoscopes are not required. But if normal handle is obstructing, then you can use a short handle one. If there is difficulty in tracheal intubation, I'll do external laryngeal manipulation using burp, or insert the tube over a bougie, or change blades, or use a video laryngoscope. Maximum attempts at laryngoscopy according to IDA guidelines should be 3, and LMA insertion 2, because if you give too many attempts, then the edema will make even the ventilation difficult, and you may land up in complete ventilation failure. If the LMA insertion is successful, then I'll either proceed with surgery or attempt a fiber optic guided intubation through that LMA, or I'll awaken the patient to do a awake fiber optic bronchoscope. You may also go with ahead with a tracheostomy after consent. Now, if LMA cannot be inserted, then you will have to proceed. I'll proceed with the emergency cricothyrotomy. So I'll confirm the ETT placement after a successful intubation by visual confirmation of the tube, bilateral chest expansion, 5-point auscultation, and capnography. Now, IDA guidelines, they emphasize the nasal insufflation of 15 liters per minute oxygen during apnea in all patients. Calling for help should be done immediately after the first attempt fails. Maximum 3 attempts at scopy and 2 attempts at LMA insertion. Blind tracheal intubation through the LMA is not recommended. Now, why awake fiber optic is not our first choice? There have been various studies done, like 180 patients of 50 kg, 50 BMI, only 6 had difficult intubation, and all were successfully intubated by conventional laryngoscopy. So, elective awake fiber optic bronchoscopy as first choice for intubation is not recommended, but ultimately the experience and ability of the laryngoscopist are the determinants. I'll maintain the anesthesia with 3% DES with 50-50% of nitrous oxygen mixture and maintain the base at 40-50 surgical level. Towards the end, I may decrease the DES and increase the base level. Then I'll maintain the neuromuscular blockade by 0.05 per kg total body weight of injection atracurium to have zero twitch on the train of 4. Prophylaxis for nausea vomiting, I'll avoid DEXA for the risk of hyperglycemia. And use ondansetron 4 mg IV around 15 to 40 minutes before the end of surgery. Analgesia will be multimodal. If epidural is successful, I'll use epidural local anesthetics. Ketorolac, first NSAID and other NSAIDs and Dexmed are equally helpful. Now, ventilator, I'll use a pressure control mode. It is more helpful than a volume control mode to maintain a ETCO2 of 30 to 40 mmHg. And recruitment maneuver is very important to reverse atelectasis. Peak inspiratory pressure of 55 for 10 seconds, followed by a peak of 10 centimeter in between. So it has been seen that when you compare DES and SIVO, the early postoperative recovery is better as compared to sevoflurane. Each sevoflurane MAC hour delays the ability to swallow by 4.5 minutes, but it's not delayed by desflurane. So if it's available, I'll prefer DES. If it's not available, I'll prefer SIVO. Also with propofol, there's significant decrease in the lung function as the surgical time increases. Emergence. I'll stop the test at the last stage. Then neostigmine glycopyrrolate according to total body weight when the TOF ratio is 0.7. I'll ensure that the patient is fully awake. This is very important. And there's no residual palsy. The patient's having eye opening at verbal command, sustained head lift for 5 seconds. All the airway reflexes like swallowing have returned, and patient is breathing good tidal volume. 25 head up position is mandatory. And if there was any difficulty in intubation, then I'll prefer to remove the tube over an airway exchange catheter if available, or a ventilating bougie. So what are the pearls? The pearls are ventilate, intubate, extubate, and recover ramped up. Use drugs which have faster onset, offset, or those which can be reversed easily. Minimal induction to ventilation time to prevent desaturation. Tracheal intubation is recommended because electively, if you intubate, then it's always better than an emergency intubation situation arising. Then caution with LMA is important in morbidly obese patient. You will use recruitment and PEEP should be used. Opioid short-acting should be used, or a opioid sparing multimodal analgesia is helpful, and you should ensure a full reversal. Post-operatively, I'll position the patient in lateral or semi-sitting position with supplemental oxygen. I'll monitor the SpO2 till the patient is either ambulatory or the SpO2 is more than 19 sleep, and I'll use CPAP in post-operatively. Multimodal opioid sparing analgesia using epidural top-ups, ketorolac, other NSAIDs, and compression bandages and early ambulation, and low molecular weight heparin for DVT prophylaxis. Throughout, I'll ensure the glucose to be less than 110 mg per deciliter. So we've seen that BMI alone does not make the patient high risk. I'll find out whether the patient's having different health conditions associated. I'll assess the airway, and then I'll confirm whether the patient is high risk, and then plan a safe and individualized care determined by the comorbidities and extent of the surgery. These are the references which I've used. Thank you.
Thank you very much, Anushri.
Thank you, ma'am.
Can we have the discussion, please? Kelkar, madam.
Good presentation, Dr. Anushri.
Thank you so much, madam.
What will be your plan for analgesia in the post-operative period?
I can use local anesthetics to epidural, analgesic dose, or I can also use ketorolac 30 mg IV TDS for 24 hours.
Can you
And,
use a tab block?
yes, ma'am. If tab block is available, it will
It is a
help.
laparotomy.
Yes, it will. Local infiltration and tab block will also help in analgesia.
It's not going to be easy to give tab block in this patient.
Yes, if
I would
sonography.
request
And
my
that-
surgeon. I'll request my
If you have
surgeon to give it
intubated
from
the
inside, if it is possible.
Ma'am, if epidural is there till the catheter is removed, then we can use epidural analgesia. Or if sonography is available, then tab block can be given if the patient is complaining of pain. But my first approach will be epidural analgesia along with ketorolac and other NSAIDs. Diclofenac can be used. Also, dexmedetomidine can be
And
used.
when will you extubate
operatively.
this patient?
Yes, ma'am.
When will you extubate this patient? Will you shift the patient to the ICU with intubation, and or you will extubate and then
the
send?
patient saturation pre-operatively and how the patient recovers on table. If the patient is fully awake, is not tolerating the tube, and he's taking good tidal volume breathing and upper airway reflexes are there, then I will prefer to extubate on table. And I will use a non-invasive ventilation if it is required post-operatively, either a NIV or a CPAP along with analgesia, so that he can tolerate that non-invasive ventilation also. And I'll keep the patient in a ramp up head up position so that it helps in increasing the FRC. And I'll try to maintain the saturation till the pre-op levels, if it's 90 or 92.
And in this scenario, your case was an emergency one. Suppose it was a planned case. In the preoperative optimization, what would be your steps?
Preoperative optimization, if it's not an emergency surgery, even weight loss is suggested because it and a diet which decreases the liver size is also said to be helpful. So I can plan that so that the even hypertension BP is lowered and even glycemic control is achieved. Because of that, I'll advise the patient if he is having to undergo polysomnography and calculate the apnea-hypopnea index so that I perfectly know whether the patient falls in the category of moderate to severe OSA. Then I'll measure the ABG. Also, entire night SpO2 measurement can be done, oximetry can be done to know if the patient has OSA. And then I'll advise him CPAP at his own place also, so that he becomes used to the CPAP. Then we can, if the patient tolerates CPAP, it will be very useful for him to have a better recovery.
And with that CPAP itself, the patient's respiratory system improves a lot.
Then also will improve with CPAP and BiPAP. And the strain on
You
the
have
heart.
to give incentive spirometry before and after. Incentive
Yes.
spirometry exercises.
Yes.
Breathing exercise.
Dr. Anushri, if I may comment.
Yes, sir.
Let me first compliment you for the immaculate slides that you had.
Thank you very much,
They were
sir.
wonderful. I see people writing 15 and 20 lines in one slide and then they only get confused.
Thank you, sir.
Another thing is, I do not like mask ventilation pre-operatively because it is not easy. Most of my
Yes,
team
sir.
members, especially ladies, they have little fingers, and these guys are so huge face, they can hardly hold this. So I invariably insert that LMS Supreme which you mentioned,
Yes, sir.
or a bearded guy. It is so difficult to ventilate, with most of the masks
Yes.
that we have. Another thing is, if I at my age of 68 claim that 16 varshapasun I have not used Macintosh laryngoscope except on a day when my King Vision has stopped working, I don't know why we are still talking about that.
I agree with you, sir.
It is a special machine invented where the light goes off the moment you go inside the mouth. I think it is already tomorrow in Singapore and in Australia. Let us also come in tomorrow. All your surgeons having all kind of scopes. Let us also have this kind of scopes. The cheapest I saw was one called as Postman video laryngoscope. King Vision के भाव में 2 मिलते हैं. With a disposable blade which is costing me $1.6. That is what, 110 rupees probably. I would not even pick it up from my bucket to give for ETO. Another thing is, Post-op also I insert LMA at the end of reversal
Yes, sir.
or just before reversal. That
Bailey's maneuver, Yogan
yeah,
said.
Bailey's. I prefer to do that because the requirement of anesthesia drops when the endotracheal tube is removed.
Yes.
So the last closer part becomes very easy, and you can slowly land him into full consciousness. One more
Yes,
thing
sir.
I do is last 20-25 minutes I switch off all my sevoflurane, desflurane, whatever it is. I switch on to propofol. Believe me, propofol is much cheaper than sevoflurane,
Yes,
and
sir.
all that agitation, etc. Everything is gone. They are widest possible awake. I do not know how many of you use that CPAP mask. Just the CPAP mask with an oxygen tube. It costs barely 300 rupees or something, But it is so good at the end of reversal and extubation. Simply put that CPAP mask, which is connected to the oxygen cylinder, and the patient gets fully ventilated nicely and inflated. So these are just a little few differences that I do in my private practice.
Yogan
But
sir, one more thing you can do is you can pass bilateral nasal airways,
that's right,
which go only up to the uvula, and they will maintain the patency of the respiratory tract. So that also can be done. Dr. Chaudhary, fantastic presentation. Thank you very much for it. You said about ABG.
Yes, sir.
So why would you do an ABG? What are you searching for?
So to see if along with hypoxia there is hypercapnia, then patient may have a type 2 respiratory failure present.
Yeah, but what especially where will you use that information? One thing is definitely you said if there is hypoxia and hypercarbia, Dr. Kelkar also suggested, she hinted you that you should put CPAP. How long will you use CPAP on this elective surgery? You will go almost for a month. You will repeat the ABG and you will find there is dramatic improvement, but again, the patient is still say hypoxic. He has become less acidotic. From 7.2 pH, he has become 7.338 or close to 7.4. But still there is hypoxia and there is hypercarbia. Now, beyond 4 weeks, your CPAP trial doesn't work. Now, what you are going
So I can use a BiPAP on this patient. If CPAP is failing, then you can use the BiPAP with 8 to 4 or 12 to 5 BiPAP or even a higher one. A BiPAP is said to have better results in those in which CPAP fails. So I may go a step further and give BiPAP to the patient and see if it's improving. Along with incentives. Can I?
Sir, Shinde sir, you are muted, sir. You have to unmute yourself.
Yes.
Yeah. Okay. Suddenly I got muted. Yeah. No, what I was saying was once you know your ABG, now what you do is when you are extubating the patient, set up a limit of hypoxia with hypercarbia, what you're going to tolerate. Of my personal is thing, and that also various articles have suggested, a PCO2 of 60 and a PO2 of 50 is still you can extubate this patient on table. Beyond that, put the patient into the ICU, let the patient come out of its own over a period of 6 to 8 hours, sometimes even overnight ventilation, and then extubate the patient next day morning. It's much safer alternative rather than to go in a hurried intubation. So the pre-op ABG is very essential to have two things: putting the patient on CPAP, the recovery mode, and whether you will extubate on table or no. That also is. What about your fluids? How are you going to give fluids?
Yes, sir. Sir, I may use if the echo suggests that the patient is having LV dysfunction, or if there is pulmonary hypertension with call pulmonale or right ventricular dysfunction or dilated RVRA, then I'll insert a central line in that patient and give CVP guided fluids. I'll maintain a CVP of around 8 to 10 on ventilator.
Yeah. And you said you will give what techniques where you dilate the alveoli, the recruitment. Sorry, I was not getting the word. For the benefit of listeners, would you be able to tell them how you will do it actually inside the OT?
Yes, sir. I'll give a peak inspiratory pressure of 50. I'll set it to a higher level, and then I will keep it for a period of 30 seconds. And after that, I'll keep a PEEP of 10 centimeters so that there is the closure, airway closure is not there. Otherwise, it will immediately be followed by airway closure if we don't keep the PEEP of 10.
Yeah. You can do it on ventilator and you can do it by hand.
We can do it by hand on
Yeah.
veins also.
If you are doing it on hand, a pressure of
Then I
40
close.
also is good enough.
Yes.
And then hold the bag in your hand.
In pressed position with CPAP valve closed, and then I'll release it and keep the CPAP valve closed for some time.
Immediately put the patient back onto the PEEP as you do it, and 10 centimeters of PEEP, as you rightly said, will help you achieve the thing. Or you can do it on ventilator, whereby you reduce the ventilatory rate from whatever you have kept to 4. So it becomes a 15-second cycle. You have kept I ratio 1:2. So inspiratory time becomes 7 to 8 seconds. So automatically what you are doing is 7 to 8 seconds of back compression. That ventilator does it. So that also you can do if you have a good ventilator and a good machine. Yeah.
Yes. Yes, sir.
Yogen, you is on mute.
Unmute, sir.
At a respiratory rate of 4 per minute, it is going to be more of pranayams than ventilation in reality.
It's just only for recruitment.
Okay. One more thing none of the speakers spoke about today. We have discussed about bariatric patients, but we have not discussed about patient who has been post-bariatric surgery. Half of these cesarean patients are going to come because they have undergone bariatric surgery just before wedding, and they are now going to come for surgery. And remember only one thing, that the surgeon has removed all the valves in between. They have bypassed the valves. Your pylorus is no more existing there. The only valve which is there is the one which is last at the bottom of the body. And the patient will vomit from that part which he had eaten 6 days back. If you are in a bad day on that day, you are in for deep trouble. That's why they always keep these patients fasting for 5 or 6 days and all, only on liquid diet. But yet you have to keep in mind that if they vomit, they are going to bring out things which they ate 5 days back.
Unmute, sir. Please unmute.
I am finished with my statement.
Okay. Sir, I would like to ask you one question. Yogen, sir, you mentioned that you practice Bailey's maneuver in all your patients. So even if that patient has a difficult airway, so do you still go ahead with Bailey's maneuver?
On the contrary, it might be easier to ventilate with an LMA.
No, sir, that is okay. Yeah, I understand
Yes.
that when the patient is not.
I'm not sure we understand.
When you realized, see, to start with, I put my LMA to ventilate, so I know that I could easily ventilate with my LMA. Number one. So towards the end of the surgery, I simply insert my LMA inside, inflate the LMA, then deflate the cup of the endotracheal tube, and then remove the endotracheal tube and simply switch on that COPS connected to this part. Patient is still relaxed enough, and patient now has got lesser resistance, and patient is able to be ventilated very nicely, and it is quite comfortable. In fact, especially those surgeries where the surgeon doesn't like patient coughing around, or a hernia patient and all, no, lap hernias and all, it really helps. It really matters a lot.
Yes, actually, even I agree with Dr. Yogen that one must replace the LMA at the end of the surgery before extubating the patient.
It gives you easily 20 minutes of the time of reversal. The slowly last 20 minutes are taken care of by LMA. You can even allow him to go on spontaneous and little assisted breathing.
Yes, that's right.
And by that time, the patient is so wide awake. I have removed my desflurane and all those things also before. He's only under propofol, and they only, of course, I love to use Connox monitor for all my patients because you just don't know what is going to go on.
Sir, I routinely practice Bailey's maneuver to all my neurosurgical patients because I want them wide awake at the end, and also do not want to have any hemodynamic perturbations, especially at the time of extubation. I was not sure whether in obese patients also, or obese patients who have difficult airway. That is a very good message today from all the moderators. Like even if you experience some difficult airway, but still you can go ahead with Belize manual in all the patients. Madam, you have to say something on this. Kelkar, madam.
Yes, I already said that I agree with Dr. Bhatt as far as changing the inserting the LME at the end at the time of extubation. Actually, I wanted Dr. Anusri to answer in that manner when I asked her about extubation. That's true. Because the LMA is much better tolerated by the patient. So the patient tolerates it without coughing. And later on, when the patient is wide awake, the patient can remove the LMA himself.
Here, madam, in case you are so much worried about the difficult intubation, you can put in an oxygen, your exchange catheter with an oxygen tubing. So now your endotracheal tube is in, you put in the catheter, take out your tube, and now put your LMA onto that. So now you have a dual mechanism. You have a tube exchanger inside and an LMA inside. If God forbid you feel that you can't ventilate on the LMA, you then take out the LMA and put in an endotracheal tube. That is another safety mechanism you can have it.
Absolutely
And
agree.
instead of that, we can put a ventilating bogie inside.
Yeah. That's same one.
Like
Same one. Yeah. There are tube exchangers, then there are what you are saying, oxygen.
I think what Manisha is aiming at is the risk of aspiration. Do you are you worried in obese patients as compared to the neurosurgical cases? That was your thought, right?
Particularly Anushri's case, it was an emergency exploratory laparotomy. So for that case, the Belize manual may not be that easy for as far as aspiration is concerned.
Ma'am, I have also one question regarding this technique. Pardon me, but if LMA is put, then is there a difference between the return of oral reflexes? Because I have read that maybe if you put a LMA, then as compared to ETT, the return of reflexes is slowed. So should we be bothered about that?
No,
like following.
Where you have read, I don't
The
know.
main reason why we should shift to LMA at the end is sometimes the patient does not tolerate the endotracheal tube. Patient coughs on the tube, and when you extubate the patient is not able to maintain the airway because of the falling back of the tongue. Because the patient does not tolerate endotracheal tube to that lighter a plane as the patient tolerates the LMA. So actually, to have a smooth transition towards awakening, this LMA technique is recommended. And that is what Dr. Yogan Bhatt rightly explained. And I haven't come across any such article. If you have come across that the return of protective reflexes come later, that means the patient's airway is compromised. That is what you want to say, right?
Yes.
But then this LMA can be kept till the patient is fully awake. So the chances of aspiration are not there. What does Dr. Bhatt has to say on this?
How routinely, madam, how routinely the people putting the Riles tube to prevent the aspiration in obese patient, but not posted for laparotomy?
See, if you put in a Riles tube,
Intubate the
inflate
patient.
the stomach, the surgeon many times needs the Riles tube, definitely. But if you have put in a Riles tube, before you put in the LMA, you can withdraw the Riles tube above the lower esophageal sphincter, so that the sphincter is not rendered incompetent. If the sphincter is rendered incompetent by the presence of the RT, then the chances of aspiration are there. Silent aspiration can occur. But then you are supposed to withdraw the Riles tube in esophagus above the lower esophageal sphincter.
Okay, thank you, madam. There is no question in the chat box.
There is one question on the youth. Yeah. There is one question on the youth for the first phase, because many of our members had joined YouTube because this form was full right from the beginning. So the question, very interesting question. In case of dural puncture with epidural needle, At what mark should we fix the catheter for continuous spinal technique? Anyone can take this question. If there is a dural puncture with epidural needle, at what mark should we fix our epidural catheter for continuous spinal technique?
1 to 2 centimeter inside the spinal space is more than enough for us to maintain a continuous spinal. So depending upon what length you have got it, add 2 centimeters. So your catheter is 2 centimeters inside. But mind you, whosoever is done continuous spinal, you got to be very, very aseptic. So every time you give a drug, you have to wash up as if you are washing up for a spinal. Complete wash up like a surgeon, because you are going to give the drug. If it is contaminated, you are sure shot going to get meningitis. And then, if you are going to keep the catheter, knot it, label it, tell everybody that it is a continuous spinal. I have knotted it so that no accidental injection of any drug should happen. Keep it there for 24 hours. The hole reduces because the fibrosis occurs around the catheter. So the chances of PDPH with an 18G or a 16G epidural needle disappear, they become very, very less. So there is a clear cut management given. So don't hide that you've had a puncture. Don't hide it is a spinal catheter. Mention everything on paper, knot it 2-3 times so that even if God forbid anybody wishes to give something, it cannot go like that. And then continue keeping it for 24 hours and then remove it. You only remove it because you've done the complication. And after 24 hours, you will see chance of PDPH go extremely down with these people. And then if it still then happens, then you have to give the gold standard, that is 20 ml of your epidural blood patch, again under aseptic conditions. That's the management.
Very well answered, Raman. Any questions in the chat box, Avinash?
No, there is no question. It's 9:10 p.m., madam. It was nice discussion. It will continue if we continue like this.
11th February.
Yeah, we will continue next session.
Next session is a master class, and again we have Dr. Hemant with us, one of the master in obesity and anesthesia.
No, even Aparna is there. She is the queen of obesity. If I am the king, she is the queen.
So we will listen to those two masters, king and queen of obesity anesthesia, Dr. Aparna Sinha from.
Again, you are looking at Dawn today.
I always look like Amrish Puri.
No.
And Prem Chopra.
Okay, we will finish.
Yes.
Yeah. I will put vote of thanks now. It was a phenomenal and a memorable day today. I thank to all our national office bearer, Dr. Venkat Giri sir, Dr. Naveen Malhotra sir, Dr. Anjali Sudha madam, for joining this meeting and with us for the release of today's MSCISA news. Today's meeting was a mixture of academic and non-academic and a celebration also. I congratulate Dr. Hemant Shinde, our MSCISA news editor for his first newsletter and for his dedicated hard work done. In spite of getting illness, I don't mention, he worked hard to release this newsletter today. His dedicated hard work only made this today. This is possible, and I have seen he was coughing also many times, but keeping his face smiling. So that's so hats off to the today's celebrity Dr. Hemant Shinde. I thank to today's faculty, Dr. Mrunal Harde, Madam Dr. Anushree Chaudhary for their excellent presentation. I also thank I also thank to Dr. Yogen Bhatt, a leader in group practitioner. I will not thank Dr. Kelkar madam, but I will do namaskar from here to ma'am, the only teacher I will only my beloved teacher. So thanks to our President, Dr. Katikar Madam, Dr. Anita Madam, Dr. Saleh Sir, Dr. Samir Soni for conducting this session. And today's second celebrity, Dr. Maya, who presented and conducted the release of MISA News so flawlessly and excellent way. Thanks to all Maharashtra Asian who attended today's webinar and this session and witnessed today's newsletter, MISA newsletter release. Thanks to Abhijit for uninterrupted technical support. We will meet soon in next month or in next week also. Thank you. Long live MSCISA. Long live ISA. Thank you. Thank you very much. I declare this meeting is over. Thank you.
Thank you. Thank you, Misa.
Thank you so much. Thank you.
Thank you.
सर मिसा न्यूज व्हॉट्सअप वर कधी येणार हेमंत शिंदे सर?
एक minute, we will stop the recording, then we will discuss. 1 minute only.
Yeah.
Yes, you can continue now.
नाही सर लेफ्ट आय थिंक शिंदे सर हॅज लेफ्ट द room. Anyways, then बघूया, let's see.
अभिजित सर आणि अखिलेश सर साडे सरांना अनम्यूट होता आलं नाही. मेसेज घातला होता मध्ये की
तुमच्याकडनं अनम्यूट करू शकत होता.
नाही, इट वॉज नॉट पॉसिबल फॉर
करता येत नव्हतं त्यांना आणि फारच बॅकग्राऊंड नॉईज पण होता.
नाही, आज खूप आवाज होता बरं का. अखिलेश
अरे आता अनम्यूट करू शकलो मी. जस्ट नाउ आय ट्राइड 100 times. But I could not. Probably it was Akhilesh end. He kept me on permanent unmute mode.
ओके. आणि त्या संक्रांत व्हिडिओला पण आपला व्हॉइस किंवा ते गाणं जे होतं ते नव्हतं मला वाटतं, की मलाच फक्त ऐकायला आलं नाही. मला आय डिड नॉट.
गाणं नव्हतं वाजत.
गाणं नव्हतंच
ना. हा तेच, कारण गाणं असलं तर खूप छान त्याला
मायाच्या प्रेझेंटेशनच्या वेळेला वर ब्लॅक अशी स्ट्रीप येत होती.
नाही, माया ते काल सांगितलेलं वर्कआउट करता आलं नाही का
सर? नाही सर, ऍक्च्युली ना ते थोडं ऍडव्हान्स टेक्नॉलॉजी आहे. मी आता माझ्या लॅपटॉप मध्ये शोधली तर माझ्या ह्याच्यामध्ये आहे ते ऑप्शन. पण इन दॅट केस आय हॅव टू बी होस्ट to accommodate all on that dais.
Okay.
So I have that facility. आपल्याला अखिलेश किंवा अभिजितला विचारावं लागेल. They must be having all these things and they can do that. तर एक 7-8 लोकांना आपण त्या डायस वर घेऊ शकतो ऑन द चेअर्स, म्हणजे डिजिटल चेअर्स, आणि वी कॅन हॅव अ प्रेझेंटेशन.
तुझं ते प्रेझेंटेशन, एक मिनिट, प्रेझेंटेशनला ब्लॅक स्क्रीन काय